We are live now.
Can I start with the presentation, Saiti?
Yes, ma'am.
A very warm welcome to all the esteemed faculty members and the delegates who have joined us today for the Benchmark Episode 5, which is a fetal medicine symposium by none other than Dr. Sneha Bhayar Madam today. Our conveners for today is Dr. Seeta Pal Madam and Dr. Chinmay Madam, both are chairpersons for FOXI for Fetal Medicine Committee and the Perinatology Committee. We have organized this webinar taking into lines that whatever good we can do and however early we can pick up things, it will be better for the future generations to come. We have a very good lineup of academics with experts from their field. I would now take the privilege to introduce our conveners for today, Dr. Seeta Madam and Dr. Chinmay Ma'am. Dr. Seeta Madam is a consultant fetal medicine and obstetrician at Apollo Multi-Speciality Hospital, Kolkata. She's also the clinical...
Monica, we'll get on with the thing. Thank you so much.
I think let's move forward, yeah.
And Dr. Chinmay Ma'am, today we welcome both of you for this program, ma'am.
Thank you.
You to please introduce Dr. Sneha Bhayar Madam, and I would invite all the faculties to please join us to evoke blessings from Lord Almighty today. Saiti, can we play the... Over to you, Seeta ma'am, to introduce Dr. Sneha Bhayar Madam. And Chinmay ma'am, can you please introduce Bhaskar Pal sir as a guest of honor?
Thank you, Dr. Monica, for the kind words and for the starting off this wonderful session we have today on fetal medicine. And it is my privilege and honor and to introduce Dr. Sneha Bhayar, who's been doing this wonderful benchmark series. Every series is a benchmark in itself, which is providing a lot of information about that particular topic. We all know her academic qualifications, but more importantly, the amount of work she has done in FOXI as a breast committee chairperson and is continuing to do so. And we wish her all the best for her candidature for Vice President FOXI. I'm sure, Dr. Sneha, you'll have no problems this time. So thank you and welcome once again to introduce this beautiful benchmark series on fetal medicine. Thank you.
Thank you so much, Seeta, for that very special introduction, I would say. A very good evening to all of you, especially Dr. Jaideep Chang, who will be joining in a while as chief guest for today's program. Madam Deepika Dekha, I think probably will not be able to join, but I just welcome her. If at all she joins later, Dr. Bhaskar Pal, who is a past Vice President of FOXI, a very illustrious personality. We call him Chanakya of FOXI. Welcome, Dr. Bhaskar, as guest of honor. And all the faculties, today the program, I have already said that it's a focus program on fetal medicine. I'm so fortunate to have Dr. Seeta Ramamurthy Pal and Dr. Chinmay Radha to convene this program. They are the experts of this field, and we are very fortunate to have them. We have Dr. Mandakini Pradhan as a speaker who will be speaking on basics of genetics, what the obstetrician should know. And of course, Dr. Chinmay herself is speaking on the fetal echo for the obstetrician. We have Dr. Vandana Bansal, a very expert fetal medicine specialist from Mumbai, who will be speaking about the correctable anomalies, which will be really fruitful and very helpful, I'm sure. And of course, Dr. Vatsala Dhadwal, who will be speaking on the fetal interventions and overview. We have the chairperson also all over the India, who themselves are the fetal medicine experts in their own accord. And we have Dr. Pragya Mishra from Patna. We have Dr. Kunda Shahane from Nagpur. We have Dr. Jagruti Murke from Amravati, Dr. Meera Aglave from Bhandara, and of course, Dr. Seeta, I have already said, and Dr. Sachin Nichitel from Navi Mumbai. I'm sure we do have two more chairpersons, Dr. Vaishali Munde from Nagpur. Vaishali has just joined. I can see you. Hi, Vaishali. and Dr. Chinmay Umarji from Pune. So all in all, I hope that this is the best possible program we could design and put forth. So I welcome all of you here, and I'm sure that this is going to be very helpful for the obstetrician gynecologists as far as the fetal medicine is concerned. At this point of time, nobody, it's not possible for everybody to be expert in the field, but as obstetrician gynecologists, what minimum we have to know for that particular subject, we should have at least that knowledge. And that is what the only essence of this program. So thank you so much, all of you, for joining. And I take this opportunity to invite and introduce our dear friend, Dr. Bhaskar Pal, as guest of honor. And we would like to have his word. As I've already stated, he was actually my committee advisor and of course, Vice President of FOXI. He was the chair of AICC RCOG, immediate past president of IAG, FOXI representative to Suffolk, chair of organizing committee of AICG. I'm sure nobody has forgotten. Rather, we cherish the fond memories of AICG Kolkata and so many accolades and posts he has held. So we are looking forward to you as a leader, Dr. Bhaskar.
Sneha, that's fine. That's enough.
definitely
Thank you. Thank you. That's enough.
over to you. Yes.
Yeah. At the outset, I have to thank two dynamic personalities for me being here. And I was just around, I've just landed in Bhubaneswar, and before I got into the flight, I was chief guest for another webinar. And that is where I said the same thing, that the only downside of being a chief guest in a program is that it makes you really feel old. But I think Sneha is everywhere. She's been a very dynamic chairperson. And Sneha, I wish you all the best for your forthcoming elections. And the second person I have to thank is another dynamic upcoming person from Maharashtra, and that is Manika Ombarda. This is a person I think people should watch. But I think I'm deeply honored by being here. It's great to be in the company of Jaideep and Deepika Deka madam if she joins. Everything in life has a life cycle. For example, if you speak to people who recruit and who are educational consultants, in the 1960s and 70s, the best profession to be was to be an engineer. I'm taking medicine is an all-weather profession. I'm not talking of medicine. 80s and 90s was the time to be an MBA. After that, it shifted to becoming a lawyer. Similarly, in medicine, everything has a life cycle. And there was a time when everybody wanted to be an IVF specialist. There was a time when everybody wanted to be a endoscopy subspecialty. That is still on. But at the present moment, I see the two fastest growing specialties are cosmetic gynecology and fetal medicine. The number of people who are flocking, I guess, because once a particular stream gets saturated, that is when people start taking up other streams. And secondly, it takes some time to realize the importance of that. So, there was a time when we would be struggling to find a fetal medicine specialist to whom we can send a scan. And now we have fetal medicine specialists come and soliciting for scans. I guess that tells you that there has been a huge expansion. And it's a great program. And I think you've got doyens as speakers and chairperson. I can see Dr. Mandakini Pradhan, the past chair of the Genetics and Fetal Medicine Committee, Dr. Chinmay Ratha, the chairperson of the Perinatology Committee, Dr. Vandana Bansal, president of SFA Mumbai chapter. And Vandana, I wish you all the best for your candidature also. And you have, and then you have Dr. Vatsala Dadwal, who was the head of the fetal medicine unit in AIMS New Delhi. And in chairpersons also, you've got another past chairperson of the Genetics Fetal Medicine Committee, that is Dr. Pragya Mishra. You have Dr. Kunda Sahane. We have Jagruti Murke from Amravati, Dr. Meera Agalve from Nagpur, Dr. Sita, who's the chairperson of the current chairperson of the Genetics Committee, Dr. Sachin Nichite from Navi Mumbai, the Chinmay Umarji, again, very young accomplished fetal medicine specialist from Pune, and Dr. Vaishali Munde from Nagpur. And I'm sure that this would be a great program, but I'm pretty sure also that exactly what you're trying to achieve, I think the general obstetricians and gynecologists we need to know when to send a patient to a fetal medicine specialist. And we also need to learn from the fetal medicine specialist when and how we should be acting upon particular situations. So once again, thank you for having me, and I wish you all the success to this program.
Thank you so much, Bhaskar, and a very good evening to Dr. Jaideep. Thanks, respected President Foxy, and we're very fortunate to have you, and you have just reached in time. So once again, thank you so much, Jaideep sir, for joining this webinar. And we've just heard Dr. Bhaskar Pal and his insights into the subject. Definitely, I would like to introduce Dr. Jaideep Tank, who is such an accomplished person with a highly decorated CV. Sir is the Deputy Secretary General of Asia Oceania Federation of Obstetrics and Gynecology. He is the immediate past chair of that is FIGO, Committee of Safe Abortion, past chair of Publications and Newsletter Committee, AOFOC, past chair of Reproductive Endocrinology and Infertility Committee of AOFOC, and also the past chair of MTP Committee of Foxy. He's been awarded with FRCOG and will be conferred soon. That is what it is mentioned. All of us know you as a very busy obstetrician consultant at Ashwini Maternity and Surgical Hospital, and also the Center for Endoscopy and IVF. He's a co-founder of Esperanza Healthcare Private Limited, Program Director and member of board of Profit IVF visiting consult for so many IVF centers, more than a dozen. So we would like to hear your precious words from you, and over to you, Jaideep sir, for your words.
Thank you very much, Neha, for that kind introduction. I hope I'm audible.
Yes, you are.
Yes.
Yes, sir, you are.
Yeah. Okay. Yeah. Thank you. Thank you, Sneha, for putting this whole webinar series together on the benchmark. And I like that you called it a benchmark, because you indeed set new benchmarks when you were the chair of the breast committee for Foxy. So congratulations and all the very best, Neha, for everything that you aspire to in Foxy. I'm also very happy that I'm sharing the platform with guests of honor, Dr. Deepika and my very dear friend, Dr. Bhaskar Pal. I think you've selected excellent topics, but topics which are, I mean, I don't know how the speakers are going to cover them in the time that they have, because you are going to speak on basis of genetics, fetal echo, correctable anomalies, and interventions. All of them rightly could be like 2-day conferences or something. So I must in advance congratulate the speakers, Dr. Mandakini Pradhan, Dr. Chinmay, Vandana, and Dr. Vatsala, and the chairpersons, Pragya, Dr. Kunda, Dr. Jagruti, Dr. Meera, Sita, Sachin, Vaishali, and Chinmay. And of course, thank and congratulate the convener, Sita, Chinmay, and the coordinator, Monica, for their excellent work for this series. I'm sure whoever attends this series will be definitely benefited and will learn something new. Thank you again, Sneha. All the very best. And thank you for inviting me. Thank you.
Thank you so much, Jaideep sir, for your best wishes and of course the appreciation about the program. We are really very fortunate to have Dr. Sita and Dr. Chinmay as convener, and of course the illustrious speakers. We do have experts in the field. Thank you so much for all the precious words from Dr. Bhaskar. And I would like to thank all the dignitaries here. And without much ado, I would like to hand over the forum to our coordinator for the academic session. Over to Dr. Monica for your, please take over the.
Yes. Thank you so much, Jaideep sir and Bhaskar sir, for gracing this occasion and blessing us with Dr. Sneha Bhuyar Madam for her candidature. We move forward to the academic session, the session by Dr. Mandakini Pradhan Madam. She will be talking on basics of genetics, what obstetricians should know. Our chairpersons for today's session are Dr. Pragya Mishra Madam. She is a consultant infertility specialist at New Life Test Tube Baby Center. She is also consultant at MGM Hospital and Research Center at Patna. She has been the Honorary Secretary General of ISOPAG for the current year, Chairperson of the Genetic and Fetal Medicine Committee, Foxy, for the year 2016 to 2018. She has helped various institutes and has been leading them. We welcome you, ma'am. Our next chairperson is Dr. Kunda Sahane, madam. She is a fetal medicine consultant from Nagpur. She has a fellowship in fetal medicine from VS Medical College. She's an FMF certified sonologist, and she's a director and consultant at Mayflower Fetal Medicine Center at Dhantau, Nagpur. We welcome you, ma'am, as a chairperson for this session, and we request you to introduce our speaker, Dr. Mandakini, madam.
Thank you, ma'am. I am Dr. Kunda Shahane. I would like to thank you, Sneha ma'am, Sita ma'am, and Chinmay Rathi ma'am for inviting me as a chairperson for today's fetal medicine symposium. I am very fortunate to introduce Professor Mandakini Pradhan ma'am. Ma'am is a well-known personality in the field of genetics. Ma'am is MD obstetric gynecology and DM medical genetics. She is professor and head at Sanjay Gandhi Postgraduate Institute of Medical Sciences, Lucknow, Uttar Pradesh. She has many publications. She has received she was a chairperson for Foxy Genetics and Fetal Medicine Committee from 2019 to 2022. She has received Bharat Gaurav Samman 2020 by World Human Rights Protection Organization and Women Achiever Award 2021 by Governor of Uttar Pradesh. We welcome you, ma'am, to enlighten us for the difficult topic that is genetics and what obstetrician should know about genetics and different tests. Thank you, ma'am.
Yeah. So, thank you so much. Can I know what's the time allotted to me?
20 minutes.
20 minutes. Okay.
Yeah.
So, I have to skip a few slides. Thank you, Dr. Sneha and Dr. Sita, for organizing something, which probably, as Dr. Bhaskar Pal said, that is going to be with us for next at least 10 years or so. And we'll be struggling sometimes to know what we are dealing with. And as an obstetrician, probably it will be a difficult task. So let me try to make something which is simplified version of what is a genetic test and So genetic test, what test we usually order is a karyotype, chromosomal microarray, whole exome sequencing. These days, many of us get to know this terminology, genome sequencing. Sometimes we hear about FISH, qPCR. We struggle to make out what it is. Then has come is MLPA, Fragile X mutation, and then targeted mutation analysis. In my next 15 minutes, I will be trying to solve this, where to do what. So we know that in the cell there are 23 pairs of chromosomes. And if we expand these chromosomes, they are double helical structure with ATGC or nucleotides, which are against each other. And then they, along with histone protein, they make a compact structure of chromosome. So it is something like akin to looking into the books in that library. We can't make out anything. We need to arrange them into anatomy, physiology, biochemistry. And then that is how it looks like under a microscope. That is our chromosomes, 23 pairs. But if we arrange them like this, then we can make out where is the anatomy books, where are the pathology, microbiology, and obs-gynae book. So we can make out what is called as a chromosomal arrangement after looking into the microscope, or it is, and then naming them. So it is something like arranging those chromosomes into pairs of 1, 2, 3, 4, X and XX or XY, as the case may be. And they are in the lab, they report something like these diagrams, and these are nothing but the representative diagrams so that it can be compared. Do not think that there are 3 chromosomes like this. There are actually 2 chromosomes of chromosome 1. The corresponding ray diagram or the bar diagram is to match with this chromosome 1, and it is called as a ideogram. And this analysis is called chromosomal analysis or karyotype or short form, many of us tell that KT. So I prefer to call it as karyotype. So what is chromosomal analysis? As an obstetrician, we should know that these are done on dividing cell. So these cells are collected and put into culture. So hence you have to have live cells for the test to be done. That is what is important for an obstetrician. And obstetrician may not know why it is so Jimsa stain and all these microscope, but it is live cells. So hence when you have a stillborn, you cannot order a chromosomal analysis where the cells are dead. So that is why that is how the test is done. So what analysis we can do or what abnormality we can pick is what if the numbers are abnormal or if there is some translocation, duplication, deletion or some abnormality. So again, going back to that same library, if you see there are three sets of the rack of one of this thing. Here again, three sets of this thing on chromosome 21 or the rack number 21, and hence it is trisomy 21. So this is abnormality of the number, and it is called, and hence the total number of chromosomes become 47. If it is a female, then plus 21, that means 21 is extra. This is how we get a report. If all the chromosomes, one to the sex chromosome, all chromosome pair are 3 in number. So the total counting will be 69, and it is called triploidy. And where do we see is in a molar pregnancy, what is called as a partial molar pregnancy. We see 69 chromosomes. It may be XXY or XXX, depending on the type of inheritance. In our clinical practice, we do see primary amenorrhea patients, and they are cases of Turner syndrome, many of them, and 45 XO is their chromosomal pattern, and hence one X chromosome is missing in them, and the total number of chromosomes are 45 in number. So this is a number abnormality. Then coming on to the translocation, few of the books got translocated to this rack, and this set of book have got translocated to this rack. So this is called translocation, and it is reciprocal because there is no loss or gain of genetic material, and hence it is called reciprocal translocation, and we call it as balanced because there is no loss or gain. So where is the clinical situation where we order for a look this such type of abnormality is, we get to see in a couple who has history of recurrent pregnancy loss or recurrent abortion. So in a couple where recurrent spontaneous abortion, in 3 to 5% cases, we see balanced chromosomal translocation. Like this is an ideogram between 7 and 11. Husband is a carrier, and hence what will happen to the future pregnancy, I will come on to it. Then here again, the 21 chromosome or this rack has gone and got attached to, all the books got attached to 14. So translocation between 14 and 21, the whole of 21 has gone and got attached, and it is called Robertsonian translocation. The previous translocation I told is a reciprocal translocation, where this is a Robertsonian translocation. So in a Robertsonian translocation, because the whole rack has gone, so the counting will be 45. And the XX, if it is a female who is a carrier, and ROB stands for Robertsonian translocation between 14 and 21. This is how the report is to be interpreted. So here is a case of Robertsonian translocation between 13, 14. 14 is 1 in number, 13 and 14 got attached here. So here is a Robertsonian translocation between 21 and 21. What is the difference? Here, the chromosomes are, 2 chromosomes are different. Here, it's between the same chromosome, 21 and 21. As a gynecologist, should I know about it? Yes, very, very important. What is 21 got attached with 21? There is no loss or gain of this genetic material, but counting will be 45 because this 2 will be counted as 1. So 45 XX Robertsonian translocation between 21 and 21. Why it is important? Here is between 22 to 22. So 2 of them got attached. So this this patient had previous 6 abortion. One couple has Robertsonian translocation between same chromosome. The risk of abnormal pregnancy outcome is 100%. And here is a couple who definitely needs donor gamete. If it is a male, then you can do an IUI. So this is between 13 and 13. Similarly, 22. Again, risk of abnormal pregnancy outcome is 100%. So we need to, as an obstetrician, we need to remember that if it is between same chromosome, then the abnormal pregnancy outcome is 100%. There we have to have a donor gamete. So what we understood is reciprocal translocation, translocating few books of one rack to other rack. Abnormal pregnancy outcome. If wife is a carrier, then 10% abnormal pregnancy outcome. Husband is a carrier, I put it as 5%, so half of it. So wife is a carrier a little more than as compared to husband. Robertsonian translocation, different chromosome, again 10% abnormal outcome. Same chromosome, 100% abnormal pregnancy outcome. I will not go on to this detail. So learning is Down syndrome, 95% trisomy, the recurrence risk is only 1%. We have to offer them subsequent pregnancy, a prenatal testing. Whether non-invasive, invasive, that is a different story. But if it is translocation between same chromosome, then the risk of recurrence is 100%. There we are going for a gamete donation. Whereas if it is between different chromosome, then the recurrence risk is 5 to 10%, depending on who is the carrier. So we need to do the karyotype of the previous child, and depending on the karyotype, we counsel and manage our future pregnancy. The second clinical situation where we get to know fetal, the genetic test is fetal malformation, hygroma, holoprosencephaly, hydrops. These are 3H. The recurrence, the abnormal chromosomal abnormality is 60 to 70% in such cases. These are all intestinal malformation, omphalocele-duodenal atresia, congenital diaphragmatic hernia, and the recurrence, the chromosomal chances of chromosomal abnormality is half of it. So 30 to 35%. This is how I even teach my student. HHH 70%. The intestinal are 30 to 35%. So I'm not going into detail. Whenever you find an abnormality, you need to look into what is the chance of chromosomal abnormality, and then you can counsel the patient. So karyotype, where do we order karyotype? Is couple with recurrent spontaneous abortion. A patient with ambiguous genitalia that is born in your labor room. Cases of primary amenorrhea. If there is fetal malformation detected in the fetal life or the newborn. Fetus with increased risk of trisomy, that has become the commonest indication. Previous child with developmental delay. Premature ovarian failure to rule out if it is mosaic Turner. And in all cases of male infertility, we need to do karyotype as the first line of first investigation that needs to be done. Next, once we have done a karyotype, we see an abnormality, but sometimes we do not see an abnormality that is not detected in a normal microscope. So not detected, but there is abnormality. It is something like opening your book and then looking into the pages of the book. Here is page number 49 and 51. So page 50 is missing. Here is page 50 is duplicated. So you cannot, if you look into the rack, you cannot identify this duplication of the page or deletion of the page. So then, and hence you need to look into every page to identify this. And the test to do so is called as a microarray or chromosomal microarray. I will not go on to this history of this. Any child who has developmental delay, the first line of investigation is chromosomal analysis. Here is a child who had normal chromosomal analysis, then microdeletion for Angelman. I thought that it is Angelman. I did the test, which was normal. Then microarray showed abnormality, and hence your next step is doing a chromosomal microarray. So there are guidelines, committee opinion. You need to do microarray if your karyotype is normal and you are detecting a fetal malformation. So deletion, duplication can be detected. However, balanced chromosomal rearrangements cannot be detected, like what we say, I told about is reciprocal translocation, cannot be detected by doing a microarray. And it looks into deeper into the chromosomal abnormality. If you have an abnormal ultrasound with a normal karyotype, there is 6% chance that the microarray will be abnormal. If there is normal ultrasound, your karyotype is normal, you are doing the karyotype for some other reason, still you have got 1.7% or there are a series of 2% chromosomal abnormality. This is why the current guideline is that if you are doing an invasive test for some other reason, then you need to offer chromosomal microarray for all invasive testing patient. So what are the indication of microarray is fetal malformation? Stillbirth. As I said, that in a stillborn, you cannot do a karyotype because the cells are dead and you need to culture them and grow them. So you have an option of doing a microarray. Any abnormality will be detected. If there is balance thing, you cannot detect. But if it is the cause of stillborn, then it is to be detected by microarray. You have doing invasive testing for any other indication, as I said previously. Previous mental retardation with a normal karyotype, the child that I showed, but you have to have pre-test and post-test counseling. There are some guidelines of it. So once you have done a microarray and you are finding that the page numbers are same all throughout the library, then what do? You go ahead and start reading every line of the page and what is called as a exome sequencing, or if you are reading the useful chapter, then it is called as exome sequencing. You are not reading from top to bottom of every page present in that library. So reading every word is called sequencing. Like this example I always give, every village should have a toilet. It's a TOILET, toilet is written. So if I just remove I, deletion of I becomes, it reads every village should have a toilet, or it can be every village should have omelette. So the meaning of the whole sentence changes by changing one or two letters of this word. Similarly, changing one or two letter of ATGC base pair changes the amino acids, and hence there is a change in protein and function of it, and hence abnormality or a disease condition. So to pick it up, here is a couple who had consanguineous marriage and a child who had neurodevelopmental delay, expired on day 3 of life. Second pregnancy was managed very rigorously in a highest medical college, and then baby expired at 22 months of life, almost similar neurodegenerative disorder. So now what did we do? We did the clinical exome sequencing, and this was little time back, and we found as an obstetrician, please do not remember which gene, which variant and what all. What you need to see is, you just see what is the type of inheritance. It is autosomal recessive. And this thing is heterozygous. That means the person who is tested or the reported person is heterozygous for that. That means he is a carrier for autosomal recessive condition like sickle cell or thalassemia, which are common thing that we keep on reading. So don't remember all these, don't remember, but look into it is pathogenic, previously reported. Okay, so now the husband got tested, and then similarly the husband was same gene, autosomal recessive heterozygous. That means the couple were carrier for this condition, and we did the prenatal diagnosis for them. So clinical exome sequencing is helpful if karyotype and microarray are normal. Test the affected child first if available. If not possible, then test couple. Test one couple first, followed by the other. Other investigation may guide you. So better to see in pre-conception period. So sometimes we know that which book to be read and which exact page number we know. That means we know that the disease condition is beta thalassemia and the gene involved is beta globin gene. So we need to look into only beta globin gene, not the whole exome of that. So for example, I have written that we know that we want to know cardiac output in pregnancy. We know that obstetrics, William textbook, chapter 4, page number 61. And we go on to this library, open this, and then exactly chapter 4. page 61. Similarly, this the HPLC will tell you that this is thalassemia trait, and we go and try to see for mutation analysis, exactly reading page number 61. So it is a single gene disorder. The disease is known, and we are looking for that mutation of that gene. And hence you will order, in that case, you will order for mutation of beta globin gene. So you are restricting yourself into this sequence of beta globin gene, or page number 49 to 79, not reading the whole textbook of Williams. So you are relieved. Here is a fetal condition, huge cardiac tumor. So rhabdomyoma, you look into the tuberous sclerosis gene. Here is hydrocephalus of the fetus. The fetus has got adducted thumb, and you look into, and at delivery the fetus has got adducted thumb. So you need to look into the gene that is responsible for it, that is L1 CAM gene. So little amount of knowledge. So fetal hydrocephalus, which is X-linked, and hence you look into what is the sex of the child, and the child was found to be affected with this, and woman was found to be carrier of it. We did the subsequent pregnancy management, and the report is homozygous normal, and hence subsequent pregnancy is found to be normal. This patient came with this photograph of previous child, and I could able to make out, and one video, I'm not going to play this video, but this is cleft lip palate with ambiguous genitalia, low insertion of the umbilical cord, and hence we could able to know that this is Fraser syndrome. We did look into that. So see, neurofibromatosis, at a glance you can know that. So diagnosis after examining, say encephalocele polydactyly, so you will know that this is Meckel-Gruber syndrome, and hence you will test for only Meckel-Gruber syndrome. So diagnosis after suspicion, previous respiratory distress. Baby died with respiratory distress. Please do not put it, baby died, just died. No, please try to examine them, try to do the testing for them. The condition that can be looked for is SMA or spinal muscular atrophy, cystic fibrosis. Previous ambiguous genitalia definitely has to be tested for congenital adrenal hyperplasia. Previous short limb, you will order for skeletal dysplasias. There are a bunch of it. Previous baby requiring blood transfusion after 6 months of life, then think about thalassemia, and please do test for thalassemia. So I will not go into fish. What is fish is you look into whether this chromosome, specific chromosome, is 2 in number or 3 in number. Similar to QFPCR also, we look into, by different technique, we look into specific chromosome, whether in 2 doses or 3 doses. So that is, and it gives a very rapid result within 48 to 72 hours, and hence no live cells are required in QFPCR, and hence we do offer QFPCR for patients where the gestation is advanced, and we wanted to rule out trisomy 21. So MLPA is a test where is done for DMD and spinal muscular atrophy. Not going into detail of it, these are all deletion disease. That means in that same line, there are the whole line is missing. So you ask a test that is called as a MLPA, and these are 2 conditions which are very, very prevalent. DMD, Duchenne muscular dystrophy, if a male is affected with muscle dystrophy, and spinal muscular atrophy is autosomal recessive condition. When any male or female is affected, early death, respiratory with respiratory distress. You think about it, and then look for this, and the test that is to be ordered is this. So muscle dystrophy, and you do it. So genetic test, karyotype is done in RSA. Chromosomal microarray is malformation with normal karyotype. Whole exome sequencing is with history of previous childbirth. Abnormality, that is you are previous stillbirth, previous abnormality, and then you look into the cause of stillbirth or the abnormality. Say for example, baby died after 1 year with seizure, developmental delay. Genome sequencing, whole genome sequencing is not to be ordered for. In clinical practice, we do not order for. Then FISH shows us number and known deletion duplication. QA-PCR is antenatal trisomy 21. MLPA for DMD and SMA. If we remember this, then we can order our test, and the test result almost tells us what is to be done. In a patient who is a male with mental subnormality, her sister has come to us for antenatal testing. Then you think of testing that male or the brother of the patient or any male member. So then first step is karyotype. If karyotype is normal, then definitely the next test is Fragile X mutation, which one needs to look into. So targeted mutation analysis, as I explained, specific disease that we have diagnosed on clinical basis that it is thalassemia. So you order for mutation analysis for beta globin G. So one example I'm left with, am I done with 1 minute then? So this is the case, was booked at 10 weeks, previous child with developmental delay, had a very nice follow-up, all ultrasound, male baby, Apgar 8-9, birth weight 3 kg, jaundice detected on day 7 of life. And the total serum bilirubin was 38, phototherapy, history of seizure on day 11, baby discharged on day 14. 1 year bilateral sensorineural hearing loss, 2 year mild diffuse cerebral atrophy, 3 years cochlear implant done in our institute, 4th year bisyllables, works with support. Just see, genetic evaluation done, microarray done normal, Fragile X done normal, currently 4 years. Just see the reports. These are the reports of the same patient. And this is the video of that patient who is yet to walk at 4 years of age. And present pregnancy, the woman comes to us at 10 weeks. Why I have put this is, see, the woman will come back to you, even if she has all these cochlear implant and whatever this thing, they want a normal, healthy child in their future pregnancy. And these tests have become affordable. And what did I do? First antenatal visit, 10 weeks. I just reviewed her history and found that it has neonatal jaundice, which leads to probably seizure and sensorineural hearing loss and developmental delay. So I did and male baby. So I did G6PD level in that baby. It came out to be 30. Normal is more than 35. I did a G6PD gene sequencing, and the child was found to have a mutation in this. And mother was found to be a carrier. So targeted mutation analysis of the mother found to be a carrier. Mother wanted a prenatal diagnosis. Many of our patients after counseling do not want. Anyway, we respect this thing. So previous male child neonatal hyperbilirubinemia due to G6PD deficiency and sequelae went undiagnosed till 4 years of age, and so many drugs which can cause hemolysis was given to the child. Now we did the amniotic fluid of subsequent pregnancy and found to be the child is found to be having G6PD deficiency. But what did we do? Ongoing pregnancy, list of drugs to be avoided at birth, we have provided them, and neonatal team was informed. So this is nothing to be worried, but however, the couple's the choice was respected. Sent for increased risk for T21. On history, we knew that this woman's brother was affected with mental retardation, lot of agitation. We got a photograph and a video, and you can see he is wearing 2 different slippers, not looking at the photographer. So he has got profound deafness. We did test karyotype normal. And what I said is, next step is Fragile X abnormal. So this is a Fragile X. And we did test the sister of the brother, and the sister was found to be a carrier of it. So fetal risk, she was referred to us with increased risk of trisomy 21. What did we found? She is a carrier of Fragile X. So both sample was tested for both Fragile X and trisomy 21. the fetal sample. Fetus was found to be a carrier of Fragile X and normal for trisomy 21. We continued the pregnancies, and she has delivered by this time. So genetic test, again, to conclude, first I talked about karyotype, live cells. Where do we order? We order in recurrent spontaneous abortion, malformation, mental retardation. That's the first step. The cost is less than 2,000, so it is doable. So chromosomal microarray, when karyotype is normal, then and there is malformation. Sorry for that spelling mistake. And in all cases of invasive prenatal sample, we do give them an option of chromosomal microarray. Our acceptance rate in our institute is more than 95%. So almost all of them, they opt for chromosomal microarray. Then comes whole exome sequencing in those who were stillborn, previous unexplained stillbirth, neonatal death. We do test the couple for a whole exome sequencing, and our results are very, very encouraging. We do get inborn error of metabolism, congenital adrenal hyperplasia, n number of conditions. So it's nice that we are able to detect it, do a prenatal diagnosis in subsequent pregnancy, and confirm that the fetus is normal, and ask them to go back to their treating obstetrician. So genome sequencing is not done, not to be ordered. Please do not forget this, that there is something called genome sequencing. It is like reading the first page of the first to last page of every book. Is it possible? Not possible. You want to read the useful, meaningful pages of the books. So FISH and qPCR for quick prenatal trisomy 21 testing, MLPF for DMD SMA, Fragile X mutation for male mental retardation, I talked about. So that is and targeted mutation analysis as per the disease. So thalassemia, sickle cell, you try to look for beta thalassemia, beta globin gene sequencing. So this is the summary of the test that we use in our obstetric practice. And this is going to stay with us. If anyone says that you send it to for geneticists for genetic counseling, please remember how many geneticists are there in India to help you out. So it is you who have to be empowered with this knowledge of genetics so that you can see your patient better, you can manage them better and do a proper counseling. So try to learn it, and it takes a little time, but then you can do that. Thank you, Dr. Sneha and Dr. Sita, for inviting me for this talk. And thank you everybody who have joined for this. Thank you.
I would invite the chairpersons to make few comments. Before that, I would just appreciate Mandakini madam. It is such a I mean, we get engrossed listening to you. So much of knowledge of genetics, and you're so well versed with the subject. It's really a great learning from all of us. Over to you, chairpersons, for your comments.
Thank you, ma'am, for such a simplified way of complex topic. And as per you said, different tests are available as a genetic test in obstetrics, but one has to be careful to see the comprehensive study of that case, so that individual case may need different type of solution as a genetic testing. So our aim is to have the genetic test which can get us a decision-making power to that couple. So thank you so much. Such a complex topic you told us very simplified way, and it is really helpful to us to make a decision and to make a precise test for our patients as far as the individual situation is after comprehensive study is needed. Thank you, ma'am.
Thank you.
Thank you so much, Dr. Kunda madam, and thank you, Dr. Mandakini ma'am, for simplifying the topic for all our delegates. We now move forward to the next academic session, that is fetal echo for obstetricians, and the speaker is none other than Dr. Chinmay Ratha madam. We welcome our chairpersons for today's session. Dr. Jagruti Murke is a fetal medicine consultant at Daffodils Amravati. The next chairperson for today, Dr. Meera Aglave madam, is a consultant for the last 8 years at Bhandara. She is also an ex-senior resident at ESI TGI MSR at MGM Hospital, Mumbai. and an ex-assistant professor at IGCMC Nagpur. We welcome both of you to please share the session.
Thank you, Monica. Good evening, everyone. Am I audible?
Yes, Jagrati.
Madam, it's a great pleasure to be here on this benchmark, and I really thank Sneha Buhar ma'am, Bhaskar Pal sir, Chinmay Ratha madam. Now everybody is waiting for your lecture.
Sure, let's.
Yes.
It's okay.
She
Let's
is
move to the lecture.
Yes, ma'am. She's a director and the lead consultant, fetal medicine, Resolution Fetal Care Center and Research Institute.
Okay, I
Senior
think Jagrati,
consultant.
just give
Yes,
me those
ma'am.
2 minutes
Yes,
extra
ma'am.
for the
If it's not
topic. Thank
needed,
you.
definitely. Yes,
Thank
everybody's
you.
good. Thank you,
Yes.
ma'am.
Yeah. Can I please share my screen? Thank you so much. Actually, Jagrati is the next generation fetal medicine specialist, and it is now nice to see the next generation coming up and
Thank you, ma'am.
actually being there with us in the thing. Like Bhaskar sir said, in the beginning, it was everybody was scared whether this specialty will actually be useful for us or not. But now it's nice that obstetricians are also looking forward to what fetal medicine specialists have to say. So the heart of the matter today is that we are going to talk about something called fetal echocardiography and what every obstetrician must know. Just today morning, I was having an argument with an obstetrician colleague who says that everybody should have an echo. So let's start with that premise. Should everybody have an echo? Now, what is an echo? So an echocardiography is a very focused, detailed, and systematic examination of the fetal heart by ultrasound in order to establish normal anatomy and hemodynamics and to rule out major cardiac abnormalities. So who should have fetal cardiac evaluation? Every pregnant woman should have a fetal cardiac evaluation. Now, every pregnant woman can be subjected to a basic cardiac evaluation, and if that is okay, then she need not have anything more unless she is high risk for cardiac conditions. So those high risk pregnant women should have a fetal echo. We'll discuss the indications. And in case the low risk pregnant women have had a preliminary scan and something there is not exactly normal, the screening cardiac examination says something could be a problem, then they should be subjected to what is called a fetal echo. So majority of the cardiac abnormalities occur in low risk pregnancy. So fetal heart should be evaluated in everybody. Point I want to make is fetal heart scanning always does not mean a fetal echo. Fetal echo is a specialized examination of the fetal heart, but every pregnant woman should definitely have the basic cardiac screening. So when can this be done? 11 to 14 weeks or 18 to 20 weeks is the regular time to do an TIFA scan. But you can try and do an echo at any point if you have to do. For example, in the 11 to 14 week scan also, there are guidelines how to do an echo. For 14 to 17 weeks, suppose you find some problem in the 11 to 14 week scan, you might want to call them after 2 weeks and see how it is. And then 18 to 20 weeks, definitely it can be done. So when we do the fetal evaluation in 11 to 14 weeks, there is an ideal cardiac evaluation, which is a direct as well as an indirect cardiac evaluation. So when we measure the nuchal translucency, we know that one of the causes of increased nuchal translucency is also a cardiac defect. We know that ductus venosus flow can be abnormal in cardiac problems. Tricuspid regurgitation, aberrant right subclavian artery, and cardiac access, all of which have been related to risk of aneuploidies, are actually markers of cardiac abnormalities because the whole concept is because cardiac abnormalities can occur in aneuploidies. Whenever you see these markers, you think of a high risk of aneuploidies, and the most common of which is Down syndrome, which we always link to the first trimester scan. Other than that, every unit will have its different protocol. For example, we do the color, we do the four chamber view in the first trimester, we do the tricuspid regurgitation and put the color Doppler to at least see equal filling of both the ventricles. Sometimes we may augment it with the tick and the equal to tick and the Y sign, tick and the V sign. And in that case, that can be an institutional protocol. So every unit will have its local protocol of how much they expect to do in the scans at particular periods of gestation. So whenever you are talking about a normal TIFA scan, a TIFA or a routine anomaly scan, you are doing at least a 4-chamber evaluation of the heart. You are mentioning that the situs is correct. You're checking that the cardiac activity is present and doing basic aortic and pulmonary tract. So left ventricular outflow tract and the right ventricular outflow tract. This much is part of a routine anomaly scan. One cannot say that we did a routine anomaly scan. We only looked at 4-chamber heart. We could not make out whether the chambers are equal or not. We could not make out whether outflow tracts are equal. Now she needs an echo. If you tried your best, did not see these things, then fine. But if you have not tried getting this axial view of the fetal thorax and looking at these 4 chambers and these outflow tracts, then it is not a complete TIFA scan. So my humble request to all the obstetricians is do expect this much in a TIFA scan and do not refer every patient for an anomaly, for an echocardiography just because nobody attempted to see even that much at a TIFA scan. So a basic TIFA has a checklist and that includes 4 chamber and the outflow tracts. So when you look at the heart, generally, this is a routine evaluation of the fetal heart. You should see the 4 chambers, the situs, position, size, axis, rate, rhythm, contractility, and then do a sequential segmental analysis from the stomach. Try and see that the stomach is on the same side as the heart, 4 chambers, LV outflow tract, RV outflow tract, 3 vessel view, and 3 vessel trachea view. And this is part of a routine anomaly scan, basic cardiac screening minding. As the science have evolved, as radiology has evolved, as the machines have got better, it is now imperative that this much is given as part of any TIFA report. So we cannot expect a TIFA report to be complete if these things are not there. Why they are not there? Suppose the woman is extraordinarily obese, the babies are just not coming into position. Then there has to be a disclaimer that we tried our best and we could not see more than this. So we'll call her for a dedicated echo later on. So these particular views, I have just put them up. I understand that all obstetricians are not like very interested in doing the whole scan or understanding everything, but these pictures, I have just put them up so that you can just appreciate how easy it is to see 4-chamber view, how easy it is to see the outflow tract coming from one of the ventricles, which is the left ventricle. It's a non-branched outflow tract. From the right ventricle, you get a branched outflow tract. And then you can put a color Doppler and see the 3-vessel trachea view to see the arch and the duct. So these are things which are not very difficult for you to understand. So even if you don't want to do the scan yourself, which I don't appreciate everyone doing, but once the scan has been done, look for these pictures on the anomaly scan report and make sure that the heart is seen correctly. If this is not there, then you have no guarantee that the heart was seen correctly. And therefore, just having a report which is written that all heart within normal limits is not enough. If there is a problem, ultimately the obstetrician is part of the group which gets accused of all kinds of issues. So please make sure that you look for these pictures on the anomaly scan report. Now, how is fetal echo then different? The devil is in the details, because in a fetal echo, you do the same scan, but you do it with a little more detailed attention, and you look at certain things in more, accuracy or in more detailing as opposed to a routine scan. So when you do a fetal echo, you do the same sequential segmental analysis, but your checklist increases beyond 4-chamber outflow and the aortic arch. You start looking at the, fetal, the venous circuits, the area behind the heart, the Dopplers across the heart valves, measurements, and take the Z-scores. Z-scores are, you can equate it a little bit with the standard deviations. They are the scores which tell us how much a particular parameter of the fetal heart anatomy is within normal limits or away from the normal limits, less or more. And based on that, you can say whether this is hypoplastic or it is dilated or enlarged. So that's not all. There are other things that can happen in fetal echocardiography, and that is tissue Dopplers, or you can have the specific things like TAPC, rhythm abnormalities, cardiac sphericity index. Now, these are all very, very hi-fi stuff, which I'm not going to detail in right now, but I'm just going to tell you that that is also possible because it is an age when women want a lot of clarity with regard to what will happen after birth. And if we are not able to give that clarity, then they are not happy. So in proper fetal echocardiography, you may have to include these things. Suppose there is an abnormality and a chamber is not well formed, you might want to include all this information for the cardiologist to tell you that, yes, we can correct it later on. But let me also admit that when we reach this stage of fetal echocardiography, we generally work in consonance with a pediatric cardiologist, and therefore the obstetrician will get a very composite report where it will be clearly told what is to be done antenatally and what is to be done postnatally. But still, that is not all. There is still more. So patients need to be categorized as low risk and high risk, depending on maternal, fetal, and familial factors that increase the possibility of congenital heart disease. The timing of fetal echocardiography in this perspective will be determined by the nature of findings and local facilities for early fetal echocardiography and may need to be timed before the routine anomaly scan. So what are the technical precautions? The primary evaluation must include a narrow sort of image field, appropriate depth, magnification, zoom, high frame rate. You should appreciate the clarity of the images that you are seeing on the other side. When you're looking at the long axis views, you are seeing structures which are not directly the common fourth chamber and all, but you are seeing something like the inferior vena cava, superior vena cava, and the right atrium. On the other side, you are seeing the ductal arch and the aortic arch in longitudinal section of the fetal heart. And this is telling you that you are extending your view beyond the regular. But to obtain these views, you have to get these technical considerations on your machine. Use proper magnification, zoom, and a high frame rate, appropriate high frequencies, optimal wall motion filters, harmonic imaging, high contrast using the dynamic range and image persistence, and a single acoustic focal zone. It is useful to store transducer presets. It is recommended the heart should occupy at least 1/3 and preferably half of the total image. So with that level of magnification, we should be trying and evaluating so that we see the details of fetal anatomy. So in the four chamber, there is a checklist. There is a checklist of how you look at the four chamber view. And all those who have trained in fetal medicine have learned this by heart by repeating again and again and again, whatever is written on the list here. But you definitely must see the, two ventricles which are equal in size, two atria which are equal in size, ventricles being separated by interventricular septum, atria having the foramen ovale in between, the right ventricular outflow tract coming as a branched vessel, the left ventricular outflow tract coming as a non-branched vessel from the left side. So you look at the valves opening in only one direction. You see the moderator band in the right ventricle. So when you keep doing this on a routine basis, day-to-day basis, you realize that it is very normal for us to recognize all these features. But as you practice, it becomes your habit. But if you don't practice, you need to get it into your rhythm, because this much is part of a routine cardiac evaluation in obstetrics. Then your outflow tracts, again, you need to make the same effort and go and see the outflow tracts so that the right side and the left side outflow tracts are crossing each other in right angles. If they are not crossing each other, see, as a ballpark figure, you can see when you see four chambered view of the heart normal, you can at least reassure that, okay, the basic pumping area and the chambers are present. Now, the problem will happen if the arteries to which they are pumping are not exactly the same, because once the baby is inside, there is no problem. But when the baby comes out and the lung circulation and the rest of the body circulation become different, if the channels are intercrossed, then there will be huge functional problems. And therefore, this establishment of the correct vessel coming out from the correct side of the heart is very, very important. So the Z-scores are available because they tell us how close the size of the heart is to what is ideal. So you have something called, the Cardio Z or other apps which give us that benefit of finding out whether these Z-scores match it. Honestly, we don't do Z-scores in every scan, but in fetal echocardiography, we do it. Because if you're suspecting that there is a narrow arch, if you're suspecting that there is a atretic valve, then it is better if you can measure it. But if you start measuring every heart, there will be more confusion. I am sure Dr. Jagrati and all the others will agree with me, but that sometimes we can create undue panic by measuring all the heart. Therefore, I don't recommend these kind of measurements in every case, but definitely when you're trying to do a fetal echocardiography for ruling out a certain anomaly, then one should go for these kind of evaluations. So this is a method of finding out the sizes of the like biometry of the heart. And if a measurement is exactly on the mean or the average, then the Z-score is 0. That means there is no deviation from the average. So it's something like the standard deviation, but a Z-score, they allow the practitioner to monitor the growth of the cardiac structures. And sometimes the variability between two observers might limit their use, but this is a very useful parameter in echocardiography. Then comes the role of color and spectral Doppler. So we don't put color in every scan. Nowadays, the new parameter says it is good, it is recommended to put color in the scans. But if you're doing a fetal echo, you cannot do away with color. You have to have a color flow assessment, and that will tell you whether the color flow is going through and through the heart chamber so that the chamber capacity is well seen. It will also show what is the flow across the valves. If it is very, very turbulent, you know the valve is atretic or small. It will show the direction of blood flow. It will detect unexpected blood flow, detect very small vessels which are unlikely to be present in normal circumstances. And sometimes the placement of the spectral Doppler gives us the type of blood flow that is happening. 3D and 4D can be used in cardiac evaluation where you need a complete spatio-temporal image correlation, where you want to see a particular vessel, where is it arising from, in what cycle of the heart it is filling up, in what cycle of the heart it is not filling, and what is the return from this vessel, how is it affecting the general hemodynamics of the heart. But this requires a lot of experience, and interpretation is a challenge sometimes. However, those are the new things that have come up in fetal echocardiography. So when we assess the cardiac function, what are we basically assessing? We are trying to assess whether it has good contractility, whether there is any valve regurgitation, whether there is any like restriction in the flow of the valve blood across the valves, and how are the indices in the working of the cardiac chambers. So we may need different techniques while doing this, but who should actually have all of these tests? They are already sounding very complicated. Many of you have already thought, oh my God, what is she talking about? Why are we listening to this complicated stuff? Because you should know which of your patients needs all that complicated stuff. So women who have history of congenital heart disease, either themselves or their partners who have congenital heart disease, or they have had a first child with congenital heart disease, needs this kind of evaluation, because what is going to happen in the next pregnancy is your responsibility. Anytime when you have done a basic cardiac scan and you suspected an abnormality, a detailed echo has to be done. Anytime you see arrhythmias in a scan, an echo has to be done. NT increased beyond the 99 centile, echo has to be done. Extracardiac abnormality, any abnormality in the baby, anywhere in the body, and fetal echo has to be done. Then there are these other conditions where, you see abnormal tumors, you see fetal height drops, abnormal karyotype, monochorionic pregnancies, or the mother gives history of intake of drugs in the periconceptional period or during pregnancy, which may affect the heart, particularly lithium, particularly NSAIDs, women who are diabetic, who have history of phenylketonuria, maternal infection like parvovirus, rubella, maternal antibody status where there are anti-Rho, anti-LA positive, which can lead to heart blocks, and assisted conception or in vitro fertilization. That is a debatable thing, but they say that if it is assisted conception, it should also be subjected to a detailed fetal echocardiography. Women with intracardiac echogenic focus, should that be an indication for echocardiography? No, it is technically not an indication. Now, by definition, it is not an indication, but I still do call a few of these patients back for an echocardiography, not because I want to look at the heart again, but that is the only way to save the baby. Because otherwise, somebody will go and take some 100 opinions and people will be scared. Someone will write space occupying lesion in the heart and they will terminate the pregnancy. So the only indication here is a common sense based indication where we do it only for, keeping them sane till we see it again. But intracardiac echogenic focus is seen in 1 in 20 normal babies. Single, multiple, right, left does not matter. And this is only a very, very minor marker for Down syndrome. So as long as she's had good screening for Down syndrome, you need not worry about it. And it is not an indication for advanced echocardiography. So limitations of use by ultrasound is, many malformations can be identified, and it is well established that some anomalies may be missed because biology is not an exact science, and that medical practice is still a biological science. These are words from a paper, not my own words, because we must not forget that despite doing so high level echocardiography, also we can miss certain things because the physiology itself is different. Ductus arteriosus, which is which is normal in a fetus, should not be there in the neonate. So this can never be picked up in a patent ductus arteriosus can never be picked up as an abnormality in the fetal life, because that is a normal thing in the fetal life. Coarctation of aorta, tetralogy of Fallot, sometimes it may be extremely, extremely mild and you may not be able to pick up everything. Many cardiac abnormalities may not be evident through the window of evaluation, and the appearance of an abnormality may change in the second half of pregnancy or after birth. And therefore, it is very important for us to understand the embryological evolutions and not be extremely hard and fast that, why was this not detected antenatally? There are some normal views and there are some abnormal views. So I started with telling the obstetricians to get used to the normal view. So the one in the green line here is the normal view of a fetal 4-chamber heart. And if you see all the other views here, they don't look normal. Something or the other is abnormal there. And whenever you see a deviation from the normal, it is a good time to ask for the fetal echocardiography. Well, the person who does the scan is the person who should recommend that I am not seeing the normal thing. But as obstetricians, I think if you get familiarized with this normal view and you realize that this person has seen normal 4-chamber and normal outflow tracts, then you will understand that there is no need for advanced checking. These are all abnormal views and these are common abnormalities as they appear. The right-sided aortic arch is actually not an abnormality, it's only a normal variation, because it can have a very good postnatal life without any correction. But all the others are different types of abnormalities. And as you can see, if you are familiar with the normal view, this looks grossly abnormal. Rhabdomyomas are big tumors in the fetal heart, like you can see here. And despite the fact that they are very big and they occupy a lot of the scan space during scan, they may still have surprisingly normal hearts and the baby may still do well. The only thing is association of tuberous sclerosis with rhabdomyomas. So a genetic test must be done. So here you're doing a heart scan, but you're ruling out something which is of genetic origin. Heart blocks can happen where the fetal heart is beating at a very, very slow rate or a very different rate. As you can see here, there's an arrhythmia that you see there. And as a consequence of that arrhythmia, you can also see a bit of pleural effusion by the side. So whenever there are heart blocks or arrhythmias, we need to work up by using special Dopplers, why exactly this arrhythmia is happening, where is it originating, and what is the implication. So that is an indication for advanced echocardiography. And then again, when you do an echocardiography, you are able to establish the exact hemodynamics. So you can counsel the patients regarding the outcome of a congenital heart disease. So whenever there is an isolated VSD, ventricular septal defect, atrial septal defect, double outlet right ventricle, or a transposition of great vessels, you know that even if you can do a good surgical correction postnatally, they will have a good outcome. So you should look for extracardiac abnormalities and genetic things, establish a multidisciplinary team, and help the obstetrician support the patient to have a final good outcome. All cardiac defects can be classified into structural, conduction, or functional defects, and whatever problems they are causing in the hemodynamics, whether too much blood is passing through the lungs, too little blood is passing through the lungs, or too little blood is passing through the body, whatever correction needs to be done can be told to the patient. What is the obstetrician interested in? She's interested, ab ye to tumne bata diya, what about the future? What do I have to do? So should I deliver this baby in my place or should I refer the baby somewhere? So if the neonate has a duct-dependent lesion, then they need to be in a critical ICU. Otherwise, you can deliver in your own place. And for your benefit, this is a guideline given by the American Heart Association about which abnormalities need a high level NICU. Something like a DTGA, sustained controlled tachyarrhythmias with high drops, needs to go to a tertiary NICU. Hypoplastic left heart, complete heart block, these need to go to a reasonable ICU. In tetralogy of Fallot with absent pulmonary valve, Epstein anomaly, TAPVC, you may consider sending them to an NICU, which means you may deliver in your place and transfer them later on. And if they have mild tetralogy of Fallot, ventricular septal defect, AVSD, shunt lesions, these cases can be managed in your own hospital, so you can deliver them with a neonatology backup and send them later when the baby is stabilized for cardiac follow-up. So a good fetal echocardiography helps in excluding detectable congenital anomalies, detects abnormalities and helps classify them in a meaningful manner to inform the multidisciplinary care team as to how to plan care, and allows time for the family to understand and accept the situation so that they can make arrangements for further care. Now, who can perform cardiac evaluation? Everybody who has that expertise can perform it. So in India, PCPNDT Act has to be followed. And apart from that, one has to acquire the skill and certification to do a proper cardiac evaluation. Reporting format. Reports can consist of a single statement, essay, or a checklist. A single statement is legally adequate, but one must understand that when you make a proper paragraph, it expresses your communication better, it impresses the clinician, and it serves as a teaching instrument. Always limit the factors that document the factors that limit your ability to do a proper echo, which is maternal obesity, abdominal scars, suboptimal fetal position, advanced gestational age, or oligohydramnios. Wherever possible, try to overcome this. Don't just write maternal obesity and leave the scan half done. Use a better transducer, review after a time gap, use variable positions, lateral decubitus position, tap the fetus, advanced machine presets, but try and complete as much as possible, because this information is very important. While it is okay to, just document that things are suboptimal, what is your skill if you're not trying to go beyond the ordinary? So the medico-legal safety documentation must be done. You use your institutional protocols, keep your disclaimers, whatever are needed, but make an attempt under every circumstance to see the best that you can. So fetal echocardiography is actually, a matter of the heart. So the heart of the matter is, with great power comes great responsibility. So if you have taken on the job of doing a fetal echocardiography, deliver it. Tell the obstetrician what she is dealing with. Give her a clear idea of the physiology of that fetal heart, and make it easy for the patient to, go forward. If it is normal, it should be normal. If it is abnormal, give her the way forward, because the first principle of medicine remains do no harm. So if you start an echocardiography, you better finish the structural and functional evaluation of the fetal heart and make it a meaningful exercise. Thank you very much.
Hello. Hello, am I audible?
Yes, yes.
Thank you, ma'am. Excellent talk. It was a big topic, but you managed to condense it into such a small and meaningful talk. So that was really excellent. Thank you.
Thank you.
Thank you, ma'am.
Always nice to listen to you, Chinmay.
Thank you, Dr. Vandana. Because I thought it is for the obstetrician, so we should talk from their point of view. What is it that they expect of an echo, and what is it that they should get out of an echo?
Yes.
Yeah. In fact, Chinmay, I would relate myself very much to this topic, because day in and day out, we are managing such high risk, pregnant women. So definitely we look for all these details, and we tell our sonologists, because we do not have the focused fetal medicine experts here. So whatever we could learn till now, and of course, I'm sure it's a revision, whatever you have said, but of course to the next level. So I'm very happy that all of us could listen to you, Chinmay. Thank you so much.
So much, ma'am. Thank you for the opportunity.
Thank you, ma'am. Thank you, Dr. Jagrati,
Thanks, ma'am.
for chairing the session. Hello. Can we move ahead for the next academic session?
Yes, please.
It is a talk by Dr. Vandana Bansal Madam on correctable anomalies, and the chairpersons for the session are none other than Dr. Sita Ma'am. She's a consultant.
Move ahead. Thank you.
And next chairperson,
Yeah,
is
I'm
Dr.
here.
Sachin Bhusite, sir.
Good
He's a
evening.
consultant at Fetal Medicine, director at the Tree Talk Center at Kharghar, Navi Mumbai. He is also a member of the Imaging Science Committee, FOXY, and a member of Fetal Medicine Committee, AMOX. We welcome you, sir.
Thank you. Good evening.
Sachin, I request that you
Good evening. Welcome, Sachin. Welcome.
Good evening, madam.
Yes, Sita.
Okay. So thank you, Chinmay, for that wonderful talk, for making that echo so simplified, and then making it easy to understand what exactly the obstetrician should look for. So thank you for that.
And I thank Dr. Mandakini Madam also, my predecessor in my committee, for giving that excellent talk on genetics. And now we are all ready to hear yet another excellent talk, I'm sure, by Dr. Vandana Bansal, who needs actually no introduction in the field of fetal medicine. She's the director of Surya Fetal Medicine Center and also the additional professor at Navroji Vadia. But she has years of experience in obs-gynae and including fetal medicine. She's currently the president of Society of Fetal Medicine in Mumbai chapter and the chairperson of Fetal Medicine Committee amongst. She has been doing and is doing wonderful work in fetal medicine and a lot of publications, with the recent credit of hers as the Best Publication Springer Best Publication Award in 2020 to 23 and Best Paper Award and also the Kamala Acharya Symposium Award. She's going to be talking on yet another important issue of anomalies which are correctable. So any anomaly detected should not be literally terminated at the drop of a hat. And I'm sure Vandana is going to elaborate on how we need to investigate it and come and reassure the parents that all is well. And that's what we need to look at. Thank you, Vandana. Over to you. Looking forward. Thank you.
Thank you, Dr. Sita, for this elaborate introduction. And thank you, Sneha, Madam, for calling me here. One second. Can my slide be seen and I'm audible?
I think we can see your presentation, but you need to open it and we can
It's open only.
Yeah, so you can just check whether the slides are moving. Yes.
Yes.
Perfect. Yeah.
Okay. So the topic given to me is on correctable anomalies. Again, a huge topic, but it is very important for obstetricians to know when we have a diagnosis of a disorder, then what do we do about it? And all of these are not ones which we would call them as for termination, and a lot of these anomalies can be managed as they come. So the global statistics are huge, and India is one of the major contributor to these birth defects. So what you need to understand is that among all the birth defects that are picked up, there's a huge amount of ones which are born and survive beyond infancy. And if these are born with birth defects, they should at least be born in a better condition than these malformed babies. So 1 second, I just want to take this here. Yes. So we all know that there are timelines in obstetric ultrasound, the 11 to 13 week scan, which probably picks up some anomalies, but the major is in the second trimester, 18 to 22 weeks. But the ones which come to us and where we need to actually manage them are the ones which are picked up late, maybe in the third trimester, where we have no option of termination and where we need to bring them into the world in a good condition. So we have all taken a full U-turn. We started off with picking up anomalies when the resolution of the machine was not so good in the third trimester. Then the resolutions improved and we started looking at a lot of anomalies in the first trimester. And now we are back with this ISWAC guideline of doing a third trimester scan and picking up anomalies. And so if you look at why did this guideline come in, is that even in a place like King's College, which is the mecca of fetal anomalies, about 25% of anomalies are missed out, and they are picked up at 35 to 37 weeks. And in India, it is bigger numbers. So 70% were diagnosed after 20 weeks. And of these, 66% could have been diagnosed between 12 to 20 weeks. So there's a huge number of these anomalies which are missed in the anomaly time and are picked up later on. Of these, the most important, the CNS, cardiac, hydronephrosis, skeletal, and GI, which are the ones which are picked up quite late in our gestation. So they could be either evolving anomalies, that is, they were not seen and not present at 20 weeks, but they presented later on. New anomalies which just present themselves in the third trimester for the first time, and ones which probably were missed during the anomaly scans. So let us not get into which were missed and which were evolving and which were just presented themselves later on. We need to start looking at these questions, whether it is lethal, whether it is severely morbid, can it be correctable in utero, do they resolve antenatally or do they worsen antenatally, and we need to monitor, and we find some new findings which come up. So these are all lethal, late presenting, which were not picked up and were seen at term. So not so good, but lethal we are not talking about. Even these highly morbid full-term babies born with meningocele, again, are disorders which are still seen in India, and these are my own hospital pediatric neurosurgery pictures, which you can see that they are picked up late and are diagnosed most of the time postnatally. So what we need to do is manage these broken expectations. A parent comes with all the excitement and then we tell them there's an anomaly. But now what do we do about them is, one, diagnose, help them prognosticate, prepare these parents and the caregivers. If there's a need for a genetic test, we do a genetic test. If it is something which is really morbid, we could also think of late termination through the medical board. But if it is something which can be taken care of, then it's better that we monitor them in utero, shift them to a hospital where you have all the team available, decide the time and mode of delivery. And so this will potentially improve outcomes. Then we need to also see whether there is something we can do antenatally, whether it's a medical therapy or a fetal surgery. So basically, when we find an anomaly, this is what our mind should think, that whether it is a prognosis which is good, then we will try taking it till term and potentially give the baby a best outcome. Or if it is something which is really morbid, then we do a genetic test and then help them in late termination, and if there's requirement for a medical treatment or a surgical treatment. So for all this, it is not one person's work, it is a work of the whole team. When you have a birth defect, depending on what the birth defect is, obstetrician is a primary physician and a fetal medicine specialist along with. And with that, you have a neonatologist, very important, a geneticist, a pediatric surgeon, and depending on the disorder, whichever pediatric specialty is required. So we need to counsel these parents, not only for the disease, the progression, the regression, the cost which is involved, the survival results, and long-term outcomes as well. So all this has to be spoken to them. So what I'm going to do in the next 20 minutes is take you through disorders which were either correctable or we did something good for the patient so that they could have a good outcome. So let me start with CNS disorders, where on a follow-up we found some disorder. So ventriculomegaly with an IUGR with an infection, ventriculomegaly with a structural defect with a genetic disorder, again a ventriculomegaly with a vein of Galen, new presenting ventriculomegaly with intracranial bleed and evolving anomalies. So first is this case, which I'm showing you, is a 40 years old IVF 29 weeks IUGR with ventriculomegaly. The structure looked all right, except that there was ventriculomegaly and the uterines were normal with a severe IUGR at first centile. And since the uterines are normal, we are more looking at fetal cause for infection. And for fetal infection, this baby was very small. At 30 weeks, only 588 grams. And so fetal etiologies thought of an amniocentesis was done, which showed a CMV positive for PCR positive for CMV. So now the problem is, do we allow this baby to die? Do we do a cesarean section or do we do a vaginal delivery? And with this absent diastolic flow, a long counseling was required with the parents, and the parents wanted to do best. She was an endocrinologist, educated enough to understand the implications of CMV. And so as soon as the ductus became reversal, steroid Maxilf, and the baby was delivered, 650 grams, 32 weeks, CMV was positive in the urine as well. And this is the look of the baby at birth, 650 grams. And this is the look of the baby after 3 months. She was put on valacyclovir, CSF reservoir was put in, 1.1 kg at 40 days was discharged, and then a shunt was placed, laser was done for retinopathy, and she keeps sending that her all neurological outcomes have been normal till now. She's almost now 2 years old. So we could have just given over this baby, but yes, whatever the parents want, we need to do the best for them and then try to take them to the best outcome. And this is the nice outcome we gave to that patient. Now, ventriculomegaly with a structural defect. This patient at 12 weeks had come to us with a DCDA twin with a dual marker which was screen positive. One baby had a fetal demise. So with a CRL, with a non-viable fetus, somebody did a dual marker which came as intermediate risk. So for CVS was done in a fish karyotype which was normal. So we reassured the parents and told her, okay, come back for an anomaly scan. Now a karyotype normal doesn't give us a stamp that the baby is completely normal. And she did not come at 20 weeks and came to us at around 29 weeks with ventriculomegaly, with the corpus callosal agenesis, and you can see that the cerebellum is okay and there is an interhemispheric cyst as well. So now the prognosis completely changed. The karyotype was normal, but an ACC is associated with a lot of other genetic abnormalities plus mental neurodevelopmental delay. So she was counseled, a guarded prognosis was given, and the parents wanted a termination. So now at 29, 30 weeks, what do we do for her? So we had to that time go through the high court. This was in COVID time, and she got infected herself and then came back at 34 weeks with an order from the court saying terminate the pregnancy. The problem now is she's 34 weeks, big baby, CNS disorder, nothing else. When the baby comes out, even with the termination, will come out as alive. So first we had to put KCL to cause fetal reduction, and at the same time we sent for a genetic test. So although we help them in termination, we also need to tell them about the recurrence risk. And here we really came out with a microdeletion in 17q21.31, which was autosomal dominant, likely pathogenic. And so we could tell her that this problem happened because of this genetic disorder. And since the parents were normal, then the recurrence risk for next pregnancy was less. And so next pregnancy, she came to us and she delivered a healthy baby. So what did we do here? Helped her in termination and also helped her in recurrence risk so that next pregnancy could be managed well. So here there's a patient, vein of Galen will usually present very late. So here malformations were all normal. And at 34 weeks, there was a IUGR with a cyst in the brain. You put on color and there was vein of Galen malformation. The problem with these AV malformation is there is a high chance of cardiac overload, and cardiac overload could lead on to high drops. So here, yes, at around 34, 35 weeks, you can see there is a right atrial dominance and tricuspid regurgitation, and also there was start of a high drops at this moment of time. So she was taken till about 36 weeks and did a cesarean section. But diagnosis was important because we had the whole team ready. A neurointervention person was ready with us, and the section was done on a working day when the team was all ready for doing the neurointervention. And after that, she had an embolization, and then a ventricular peritoneal shunt was put in, and the baby did well. So we've done such 4 cases, diagnosed at 38, 35, 34, 34 weeks, and baby weights were also good. We found that the ones which were bigger in size, if there was cardiomegaly, if there was pericardial effusion and tricuspid regurgitation, they did not do so well. But the ones which were small, 1 and 2 centimeter ones, they did well and did not require embolization as well. So now disorder which was not present and later on detected. So this had 2 babies which had died. First one did not cry at birth, died after 2 days. Second one lived for long, but had query Dandy-Walker syndrome. Section was done and baby was not able to sit and then died later on. So they came to us at around 24 weeks of gestation, perfectly looking brain. There was no Dandy-Walker, and because the index cases were not worked up, we said, okay, let us continue with whatever we have, and we monitor this baby. She came every 2-3 weeks very well, and then suddenly at 37 weeks came with decreased fetal movements. And as soon as we put the probe on the head, and you could see huge intracranial bleed. The baby was almost floating in the liquor. The bladder was badly distended because of no passage of urine. Liquor was normal. The Dopplers were perfectly normal. Umbilical MCAs were normal. Look at the growth. The growth was growing well, and there was just a intracranial bleed. So looking into literature, yes, there is something called as a perinatal stroke, which happened in utero. And in utero, she had a hypoxic ischemic encephalopathy, within an hour, we did a section, clear liquor, 3.1 kg baby, did not cry. Baby was pink in color, but limp at birth, and she had bilateral cataract also. All investigations were done, but finally we removed the baby from the ventilation, but we kept the DNA saved, which is to be evaluated. So it was an in utero stroke. So if everything normal, also don't say 100% that the baby is going to come out well. You need to monitor and follow up these patients. Another evolving anomaly. This is a recent one, came with binder syndrome. So we thought there is dysmorphism, but we also saw calcaneal calcification, which puts us into a diagnosis of chondrodysplasia punctata. So we said growth is normal, but there is possibility of chondrodysplasia punctata. So an amnio was done, and it showed iCardia syndrome. So now iCardia syndrome is something which was homozygous, autosomal recessive, pathogenic, but the parents wanted to continue this pregnancy. So we said, okay, but iCardia is associated with progressive encephalopathy. There was nothing in the first scan at 20 weeks, 23 weeks. And then at 29 weeks, we started seeing this calcification in the thalamus striate area. Plus there was megacisterna magna. The cerebellum looked a little small. Corpus callosum was okay. But by 34 weeks, those calcification had increased. The corpus callosum looked more thinner. The cerebellum became smaller in size. So the diagnosis was already made, but the antenatal scans in the 23 weeks did not show anything except the flattening of the nose, and later on developed into all this. So this is a baby which is born and is having difficulty in progress of this patient, and she has got multiple convulsions are happening in this baby. So here we have a diagnosis in hand. We know it is an autosomal recessive disorder, and so the parents need to be tested, and every pregnancy needs a testing. So now CNS is something which comes up suddenly, and you need to follow these up. Cardiac is again another disorder, which I think Chidmay had spoken about, rhabdomyoma. So here it's a DCDA twin, both babies perfectly normal at around 18 weeks of gestation, and at 22 weeks we could see a rhabdomyoma. So did we miss it at 18 weeks? No, it just presented later on, and later on it became more bigger in size. So we need to follow these up and look for signs of cardiac dysfunction. See, huge multiple rhabdomyomas started with one and then increased, and then multiple of them. So testing one baby or both the baby was a concern, but we tested one of the baby and it had tuberous sclerosis, autosomal dominant. So we could counsel the parents in beforehand only that they could be an association with ash leaf macule and convulsion, and this baby does have convulsion. So we could make the diagnosis, we could test the other baby, the sibling of this twin, and the parents, and all of them were normal, and so the recurrence risk was almost zero in this patient. So cardiac, again, lots of these, especially Epstein anomaly, is something which needs to be followed up because they can be associated with arrhythmias and can later on lead on to high drops. Again, a patient with supraventricular tachycardia, cardiac abnormalities I'm showing you. If you have something like this, it is a cardiac output becomes less, and they will develop into regurgitation, and also later on leading on to high drops. So these supraventricular tachycardia needs to be managed if it is happening continuously, and you could give digoxin in these babies, and it became well. So now coming to thoracic, of this CPAM is something which I need to speak to our obstetrician, because this is a disorder which resolves. So you see here, this patient came to me for termination at 23 weeks of gestation with a huge echogenic lung. So this is a CPAM with a CVR of 1.3. And so we told them, this resolves, let us follow it up. And then again, it is not genetic and could be managed. So either we do expectant management, we could give her steroid, and if there is a cyst, then we could put in a shunt. The prognostic factors need to look at. So you measure the CVR ratio, and if it is more than 1.6, if there is high drops or if there's a large cyst, then prognosis may be bad. But here, this patient, although looked so huge and bad, by the time of term, both the lungs have become all right. The heart has come in the normal position. And this is in COVID. We delivered her vaginally at 40 weeks, 3.2 kg, did not require any surgery at all. So we actually looked at our own CPAMs in the past 5 years, and the ones, some of them, in spite of our telling, terminated. Either there was an anomaly or a hydrops or a single umbilical artery. But the ones which continued, 66% of them survived, and only few of them required surgery. So the trend that we saw is at 26 weeks, the ones which remain, they do not increase much in size after 26 weeks of gestation. So hold on till 26 weeks and they will not increase. Another CPAM where there's a huge dominant cyst. Here it doesn't resolve so easily. So at 23 weeks and 29 weeks, it's become more, the mediastinum shift has happened. And by 33 weeks, it is still huge one, but it did not develop hydrops. So we did not put in a shunt, and the baby was operated at birth at full term, and the baby did well. So CVR again, if the ratio is more than 0.5, they need surgery. Pleural effusion, again, very subtle pleural effusion, started out bilaterally at 21 weeks. She is an ortho professor herself. And we said, okay, we may put in a pleuroamniotic shunt, but let us first test the baby. So when we tested the baby, we also aspirated the pleural fluid to see what happens to it. And we sent for everything. And everything came normal except the exome, and the exome showed a Noonan syndrome. So when we followed her up, by the time this Noonan report came, it was 3 weeks, and she was now 23 plus weeks, and the pleural effusion had reformed. So when you aspirate, you still need to follow them up. You need to do the genetic test, and here it was a Noonan syndrome. So aspiration or the shunt is not going to help in this case. So follow it up, and if it is so bad, they actually terminated this pregnancy because of the Noonan syndrome was present or not. So here now going on to GI disorders, esophageal atresia, duodenal atresias, implications are more related to genetics, but lower down obstructions are more associated with, just follow them up. And the cloacal and large bowel also have a bad prognosis. So you need to know which level of obstruction that we are looking at. Here there is a duodenal atresia with a double bubble sign, and there is reverse peristalsis, which we can see. Association is very high with Down syndrome, and there was a VSD also seen, and the baby was trisomy 21. So we could say duodenal atresia is surgically correctable disorder, but we need to test. So TE, fistula, and duodenal atresias need to have an amniocentesis. However, something like this, it is multiple bowel loops seen at 32 weeks. So it is some kind of a small bowel obstruction. Here, there is no need for genetic testing, but you need to follow these up for dilatation and for meconium cyst, and follow them up and be ready for an obstructive phenomena which needs to be managed immediately at birth. So deliver in utero transfer to a pediatric surgical team. Here she was operated and did well. So one very rare disorder, but we saw a lot of them in our 5 years, 10 patients of meconium pseudocysts. So the smaller the meconium pseudocysts, they do well. Here, all these are small meconium cysts, which were less than 3 centimeter. They regressed. So not necessarily meconium pseudocysts need to be terminated. They probably regress or they remain the same. But if the size is more than 3 centimeter, like here, these had a problem. There was a hydrops, there was an obstruction. One of them died immediately after, and the second one during the surgery died. So large size of pseudomeconium cyst have a bad prognosis, but smaller ones might even resolve, but some of them remain, which can be evaluated postnatally. Anterior abdominal wall defects are simple ones. Omphalocele require an amniocentesis to look for any genetic disorder, but these do well. So you just have to see that there is no obstruction to the small bowel, what is the size, and at section time, let this membrane not get ruptured. So deliver the baby very carefully. And here you can see a huge omphalocele, which was, membrane was not ruptured, and operated and did well. On the other hand, gastroschisis, is small bowel outside. There's no membrane covering, usually not associated with aneuploidies. But here again, bowel obstruction is something that you need to look at in the gastroschisis or inside also. And if there is an obstruction, the prognosis becomes bad. So here you have one small bowel which is all out, and we've done a glove cover over it and allowed the baby to be managed by the pediatric surgeon. Sacrococcygeal teratoma, she came from Dubai, huge one, again in the COVID period, large one, polyhydramnios, high drops, cardiac dysfunction again, but was operated in a tertiary care center, operated, and you can see those buttocks with the sacrococcygeal teratoma removed from here. Now coming to renal is very the most common of all the disorders, and usually they are the ones which you can follow up and they do well, and we follow this UTD classification. So just showing you one case of a renal disorder, again a twin pregnancy. So one baby, normal kidneys, the other one had a PU valves and badly hydronephrotic kidneys. So you could call it as UTD 823. So the kidneys were bad, the PU valves can be seen, distended bladder. The kidneys were already echogenic at around 23 weeks of gestation. So there was an option, shall we just reduce this baby and allow one baby to continue? Or do we allow this baby to get worsened and allow the other baby to continue? So a lot of things have to be counseled, and the parents were ready. Let this baby get damaged as much, but we want one full-term baby at least. And so we followed these, both kidneys became more echogenic, then a urinoma formed, then there was a perinephric urinoma, then the other kidney also became bad, and it was no liquor around this kidney, and huge dysplastic, both kidneys were seen, but the other one went on, and we went on till 36 weeks. So we thought the baby is going to come out and may have a problem, but see here, this was both the babies, they send us at Christmas saying, you find out which was the baby which had the problem. Both babies did well, although this one required a shunt as well as required a lot of things to be done for it. But yes, we could follow it up. We could give it to the nephrologist to manage and the urologist to manage, and both babies are doing well. And probably one of them will require a renal transplant later on. Again, here there's a patient, we may not think of what is a disorder. Here the kidneys were mildly dilated, nothing else, and we saw urethra which was distended with a cyst inside. So urethral dilatation, male penile urethra, and both kidneys mildly dilated. But the kidneys became little smaller, but they were not significantly dilated. We kept seeing the scrotum and the penile urethra, and the Dopplers were normal. To continue till term. And in the meantime, we had done an amnio and the karyotype was normal. And this is what it came out. We would never think that there can be a double genitalia, a female genitalia and a male genitalia parallel to each other. So it is not ambiguous genitalia, it is two genitalias parallel to each other. So we would always see this male while the karyotype was a female. So we went back and saw that amniocentesis report, and we asked the lab. She said it was female, and we always kept thinking it was male, and they kept thinking it was female, and it was two genitalia. But we again sent for a karyotype, which again came out as female. So the male genitalia was operated. She also had an anal atresia, which was also operated, and colostomy was made. So this baby is now being reared up as a female. So difficult cases, it doesn't mean that we just leave these babies. You can't write off these babies. You still need to do the best for them. And this is that beautiful girl which is being reared up by a female. The father is so happy. So last 1-2 cases, 28 weeks, severely hydropic, large pleural effusion, lung is squashed to one side because of this pulmonary sequestration, a huge lung that we are seeing on one side, and she was getting a blood supply from the aorta directly. Hydropic baby, she's 28 weeks. So she said, we want to do the best for this baby. So we actually put in a shunt into the pleural fluid, but within 3-4 days, it filled up again, the hydrops again formed. So it was basically the pulmonary sequestration was causing a cardiac overload, and so this formed again. So my NICU being very good, we aspirated it again on the table and did a cesarean section and exit at the same time and intubated this baby. This baby 1 kg dry weight was monitored and then operated upon. This pulmonary sequestration baby was operated on day 8, and it is the smallest neonate antenatally diagnosed with bronchopulmonary sequestration world over, which has been treated, and this baby went home. What else? We have a conjoined twin here. This conjoined twin parents wanted to continue this pregnancy. And so what do we monitor for them? You need to see what is the site of the conjoint, what vessels are attached to it. And here there were 5 cord. This was only fused at the level of the liver, and only the liver was. So here our issues was, how do we follow them up? Do we do Dopplers? Do we do Leica? Leica is AFI or largest vertical pocket. Does these conjoint have TTTS, TAP, stillbirth? Nothing in the literature. Then we could reach till 34 weeks. Do I deliver at 34 like monochorionic, or do I let them go till 36 weeks, 37, 38? Classical or lower segment? No idea, nowhere anything is written. So finally we made a little larger incision, phenanstill incision, made a lot of space, and then we delivered this baby, which is fused at the omphalophagus that we saw. And you see there are 5 vessels we are seeing. So even if it is conjoined, the parents do want to have the best outcome. And so these babies were operated. The team of pediatric surgery was also ready. First, we delivered the baby, stabilized, and then the team of our pediatric surgery operated for 6 hours to give these babies a good outcome, and they are doing well. So last of all, intrauterine transfusion that we do, I just showing you a triplet intrauterine transfusion. So RH isoimmunized triplet pregnancy was being monitored and sent to us at around 28 weeks with severe anemia of all the 3 babies. So at 28 weeks, our option was, do we deliver all the 3 triplets, or do I give transfusion to all the 3 triplets? So we actually give transfusion to all the 3 triplets, and about 70, 60, and 50 ml. All 3 babies were given at the same time by turning on one side to the other side and inside. And then all these 3 babies were pulled on for more 5 weeks, and at 34 weeks, because of help that we had to deliver her. And these 3 babies were born, and they were, this is their 6 months outcome of all the 3 boys. So this is the first world ever case of triplet pregnancies which have survived intrauterine transfusion, and it has been published in the BMJ recently. So my last slide is that when we have a disorder like this, what all do we want to do? We need to have it. What benefit this scan gives us when we see an anomaly is we need to monitor these. We could transfer her to in utero transfer. We would time the time of delivery depending on what is the disorder, have the whole team ready with us. If there is a surgery required, we do a fetal therapy. If it is termination which is required, help the parents to go through that process. And in all this process, we try improving the perinatal outcome in these babies which are born with birth defects. Thank you. Thank you.
Sita ma'am?
Hi, Sachin, you want to give any comments for the talk? And then
Madam did not leave any scope for the comments. Basically, these correctable abnormalities is a gift from fetal medicine only, because prior it was only abnormal or normal. So there is no better person than Vandana madam to speak on this talk.
Thank you.
Thank you so much,
talk,
madam.
very
Thank you.
excellent talk,
Fantastic.
as usual. Covering all aspects of anomalies that can be corrected and which needs proper counseling and management. So thank you once again, and best wishes for the future for you. Thank you so much.
Thank you.
Thank you, madam. Thank you.
Sneha ma'am?
I think it's been a wonderful session so far. And Dr. Vandana, your cases were really like extraordinary. And I think these are really inspiring for people who are working in different settings, that at least there are centers like this which are able to cater for these kind of complications, and to be able to take them to a logical conclusion and give a good outcome is really satisfying for the parents. And that's what the whole purpose of fetal medicine is. So fantastic cases. Congratulations again. And with that, we need to move to the next session. So, Dr. Monica.
Hello?
Yeah,
Ma'am,
yeah.
am I audible?
Yes, we can hear you.
Monica, we can go ahead. No problem.
Yes. With this, we move on to the last and the
I would just say
question.
I'm speechless. After Dr. Vandana's speech, I'm speechless. I'm just amazed. Thank you, Dr. Vandana.
Thank you, ma'am.
Thank you, Vandana ma'am, and thank you, Sita ma'am and Sachin sir for sharing this session. We now move ahead with the fourth topic, that is fetal interventions and overview by Dr. Vatsala Dadwal. The chairpersons for today's session, Dr. Vaishali Munde madam and Dr. Chinmay Umarji sir. Dr. Vaishali Munde is the Director of Divine Care Fetal Medicine Center at Nagpur. She is an active body member of the EC of CME Task Force Committee. She is also the faculty for FMM UK Certified Fetal Abnormality courses, which was held in 2023. We welcome you, ma'am.
Thank you so much.
Dr. Chinmay Umarji is a fellowship in fetal medicine and is a consultant at Umarji Hospitals. He is also the in charge of the fetal medicine unit at the BG Medical and Session General Hospital. He is the secretary of the SFF Greater Pune chapter.
Thank you, ma'am. Thank you for your kind input.
Thank you, sir. May I request the chairpersons to please carry on with the session?
I will, Shali, if you want to start.
Yes, sir. Hello, good evening to all. After these interesting sessions, I would like to continue with the more interesting topic, and that is fetal interventions by none other than Dr. Vatsala Dadwal. She has lots of research and papers. She has so much contribution to the field of fetal medicine. She is chairperson, past chairperson, AOGD, Fetal Medicine Subcommittee, 2017-19, and Secretary, Association of Obstetrics and Gynecology, Delhi, 2019 and 20. I would like to continue with ma'am's talk without wasting the time. Thank you so much.
Thank you. I'll just share my slides. Is it visible?
Yes, ma'am.
Clearly.
Thank you. And I would like to congratulate Dr. Vandana for an excellent talk, spellbinding. Really beautiful talk. So moving on, I will be talking about an overview of fetal interventions. So like Dr. Vandana said, it is always a teamwork. We have an obstetrician, a maternal fetal medicine specialist, a genetist, a neonatologist, pediatric surgeon, sonologist, and other subspecialties. Also, when we have a fetus with anomaly who needs to be looked into. So a little bit about the ethical issues, which it may come to our mind when we talk about fetal interventions, whether maternal beneficence and autonomy should be taken more important, or the fetal beneficence and autonomy, and also whether the fetus has a legal status as a person, and interventions, whether they should be done in fetuses with other anomalies or aneuploidy, or is it that we are converting a lethal condition to one of survival with morbidity? Or sometimes it may be the interest of the treating physician doing the procedure which may not be useful for the fetus. So we have to be very careful when we proceed with any fetal intervention, keeping all these in mind. And with the new MTP Act, there's always an option of MTP for these mothers. So this is a graph showing how over the last few decades, work has progressed on TTTS, on the Eurofetal study, use of FETO for CDH, etc. So what a trend is that we have moved from anatomical repair, this open fetal surgery, to some physiological in utero manipulation, mostly like fetal image guided surgery, so that you can avoid damage to the organ or tie the time till the fetus is born and definitive corrective measures can be done. And of course, fetal endoscopy. And this is because of the availability of better instruments and machines, are better understanding of disease process, that fetal therapy and fetal interventions are possible. But again, we have, before proceeding for any intervention, we have to rule out other malformations, chromosomal anomaly. We have to counsel to the couple, the complications which could be to the fetus or the mother because of the procedure, and should only be indicated if it is beneficial. And if diagnosed later, we still have the option of MTP nowadays. So when we talk about fetal interventions, there could be medical interventions, that is transplacental therapy, which is the drug you give to the mother, crosses the placenta to the fetus. And this has been used in the treatment of various arrhythmias, thyroid disorders, and fetal infections. And even when we give steroids for pulmonary maturity is an example of medical intervention of fetal therapy. Then there are also ultrasound-guided procedures like amnion reduction, fetal reduction, intrauterine transfusions, management of complicated monochorionic twins, use of fetal endoscopy for CDH, etc., and open fetal surgery. So here's a list of conditions and that in which fetal therapy can be offered, like CDH, CPAMs, bronchopulmonary sequestration, exit for chaos, fetal arrhythmias can be managed, also like complicated monochorionic twins, obstructive uropathy. So there's a whole long list of procedures that can be done for fetal well-being. So the most common procedure and the most successful that has been done is in utero transfusion for fetal anemia, and it is the most successful of all procedures. So for us, like it's mainly fetal anemia because of RH isoimmunization that we do transfusion for, but there may be other indications for giving intrauterine fetal red blood transfusion. So the RH isoimmunized mothers are managed by, once they reach the critical titer, they're managed with middle cerebral artery peak systolic velocity. And once this value rises more than 1.5 mom, there's a suspicion of moderate to severe anemia, and then we proceed for intrauterine transfusion. Can be given as early as 18 weeks, and the last one is usually done at 35 weeks. After that, we would prefer to deliver because there are always complications associated with the procedure. So what is the procedure? It's an O-negative fresh blood that we transfuse to the baby at screen for infection, and it is tightly packed, so a small volume will increase the fetal hematocrit. We usually use a 20-gauge spinal or a Chiba needle to access the fetal vessel. And we always paralyze the baby before doing the procedure, and we have to take a sample pre and post transfusion. If the fetus is viable, then we would give a corticosteroid cover and be ready for an emergency cesarean in case fetal bradycardia occurs during the procedure. So first of all, it is very important to you do your ultrasound and be sure that the fetus has a very high suspicion of anemia before you go for an invasive procedure. Do an ultrasound to localize the placenta and cord and map out where you're going to insert your needle. Usually we prefer the placental end because that is fixed, so that entering the cord is easier. Free loop is difficult because the cord keeps slipping under the needle. Or we can use the intrahepatic portion of the umbilical cord. Always paralyze the baby because the movement can dislodge the cord and cause damage to the cord. So once the vein is punctured, we take blood for fetal hematocrit and immediately do the hematocrit in the OT itself with HemoQ. And if the fetus is anemic, we calculate the volume to be transfused. There are formulas, and start transfusion at 5 to 10 ml per minute. Here we are giving intravascular muscle relaxant to the fetus. And the goal of transfusion is to raise the hematocrit to 45 to 50%. And we take a post-transfusion hematocrit, which will help us to plan out a next transfusion. After procedure, we monitor for fetal heart until the fetal movements return before shifting the mother to the ward. So here you can see the needle entering through the maternal wall, the abdominal wall, uterine wall, placenta into the cord. So we enter with a quick jab and take the first sample for the hemoglobin, and then depending on the severity of anemia, you calculate the amount of blood to be transfused, and then you can see the blood flowing through the cord. So this is another small clip in which intrahepatic portion of the umbilical vein has been used. So the advantage is that it is a vein. So if you're using the cord, there is a small risk of puncturing the artery, which can cause spasm and fetal bradycardia and may necessitate an emergency cesarean section, which is not the case here. And if there is any leakage from the puncture site, it collects in the abdominal cavity and gets absorbed. But there is no difference in the perinatal outcome, whether you use the intrahepatic portion or the cord insertion of the umbilical cord. So after the first transfusion, we have to see when second transfusion is required if the fetus is not at 35 weeks. MCA-PSV does not work very well for subsequent transfusion. So we usually do MCA-PSV also, and then also look at the rate of decline in the hematocrit to plan the next transfusion. So this is one procedure which gives more than 90% survival. But there are also procedures, related complications, and the most severe one is fetal bradycardia during the procedure. If it persists for more than 3 minutes or there is poor cardiac contractility, we may have to rush in for a cesarean section, and sometimes may even lead to fetal death or neonatal death. So every time you do a procedure, there is a 1.6% risk of losing the baby. So the next condition where you need to do interventions is in the complicated monochorionic twins. And why? Because monochorionic twins have interfetal anastomosis, which leads to a lot of complications. So these may allow a unidirectional flow or a bidirectional flow. But if there is discordance in blood flow between the two twins, leading to chronic unbalanced transfusion, it leads to twin-to-twin transfusion syndrome. If there is discordancy in the placental territories, it will lead to one baby not growing well, that is selective fetal growth restriction, or they may be anomalous for, they may be discordance for fetal anomaly, and typically we have a trap in monochorionic twins. So the problem with all these complications is that it may put one fetus at risk of intrauterine death, and if that occurs, the other twin can die in 12% of the cases or develop neurological handicap. So sometimes we may have to reduce a compromised twin if the pregnancy is remote from term to let the other twin survive or do some other procedures. So the condition which is has a standard of care treatment and has good outcome is the twin-to-twin transfusion syndrome. If it is stage 2 or beyond, the perinatal outcome is very poor if you don't do any intervention. So this is basically a staging for twin-to-twin transfusion syndrome, in which one baby has oligohydramnios, other has poly, and depending on other findings, we can do the staging. So if it is stage 2 or stage 4, then 16 to 26 weeks, then we should do laser photocoagulation of the anastomotic vessels to improve the outcome. But stage 1, in cases where there is cross poly or the short cervical length, we may proceed to do laser. So how does laser work? So you have these anastomotic vessels on the surface. So you have these vessels coming from both sides and dipping down. So basically these are superficial vessels, although the anastomosis are deep, but we can coagulate all these vessels on the placental surface. So that makes the placenta in almost two. So dichorionizes the placenta. So each baby has its own placenta and the basic pathology is treated. So that is done by the use of fetal endoscopes. We enter into the cavity of the recipient twin, which has polyhydramnios, and reach the fetal equator where we find this anastomosis and we can coagulate them. So we enter into the amniotic cavity of the recipient twin with the trocar cannula, introduce the fetoscope, and with the laser fiber, once we have identified the anastomosis, we can coagulate them. You can see these pairing vessels here. So how does it translate into outcome? So the randomized controlled trial, the Eurofetus study showed that compared to amnion reduction, laser in the management of TTTS improves survival of one or both twins, and also survival free of neurological complications is better in pregnancies treated with laser. In a recent study of more than 1,000 pregnancies, they found that survival rate for one twin may be as high as 90%, and for both the twins for one twin as high as 80%, and for both the twins 63%. Again, because of invasive procedure, it has its own complications, which also needs to be kept in mind when we do the procedure and counsel the couple. So sometimes we may have to go ahead with fetal reduction or selective termination of one of the monochorionic twins. In dichorionic, it is simple. We can put KCl into the thorax or the heart of the fetus we want to reduce. We cannot use that method in a monochorionic twin because this KCl can go over to the other twin because of the anastomotic vessels, or when one of the twins that we're reducing is dying, it creates an area of hypertension or low pressure, and blood from the normal twin flows towards the dying twin, causing ischemia, leading to neurological damage or death in the normal twin. So we have to use a technique which is called cord occlusion techniques, in which you occlude the umbilical cord of the fetus you want to reduce. So methods could be radiofrequency ablation, interstitial laser, or you can use bipolar coagulation, bipolar forceps to coagulate the cord. Selective fetal growth restriction is a condition in which one baby is not growing well. So that baby will be smaller. The estimated weight is less than 10 centile, and there is a growth discordance also. So once you have diagnosed the condition, we have to stage them, because these smaller SFGR with the normal blood flow in the umbilical artery usually have a good prognosis and then can be managed expectantly. But the stage 2 and 3, which have either completely absent or reversed end diastolic flow in the umbilical artery, or intermittent absent or end diastolic flow in the umbilical artery, are at a higher risk of intrauterine fetal death in one of the twins. And this condition can present as early as 16 to 18 weeks. So there is a role of fetal reduction when you have stage 2 or stage 3 selective fetal growth restriction. If there is severe discordancy, the gestational age is less than 24 weeks, and there is DV, like ductal venosus PI is more than 95%, because this fetus may be heading for an imminent demise, and that may jeopardize the normally growing twins. So here we have a role of reducing the fetus. And after reduction, the outcome improves markedly for the remaining twin. The other condition in which we do fetal reduction is trap twin reverse arterial perfusion, because if you do not, then the pump twin, the normal twin, can go into cardiac failure, develop hydrops, and even die in utero. And even polyhydramnios that occurs can lead to preterm birth. So most of the time we are managing trap by doing selective reduction of the trap twin by 16 weeks of gestation. So what we used mainly for reduction is a radiofrequency system. So this is a radiofrequency generator, and this is a radiofrequency needle with the tines at the end. So this is inserted into the intra-abdominal part of the fetus, intra-abdominal intrahepatic part of the fetus, close to the where we have the intrahepatic part of the umbilical vein. So after the needle is introduced, we open the tines and then pass the current. So a high voltage current is passed, alternating current is passed, which raises the temperature, causing cord coagulation. And this, once you open the tines, it covers an area of 2 centimeters. And after the procedure, you can see that the blood flow is stopped and the other twin is normal. So the trap twin is reduced. So this improves the outcome for the pump twin from 50% to 80% after reduction of the trap. Sometimes you may have to reduce the fetus because they may be discordant for anomaly. So one other method is that you can use a bipolar forceps with which you can catch hold of the cord of the twin you want to reduce, pass a current, and it can cause cord occlusion. This is technically more difficult. RFA is a little easier procedure to do. And here you have to enter into the maternal abdomen through a trocar into the sac of the fetus you want to reduce. Then you have to introduce your bipolar forceps, and you have to try to catch the cord. So you should catch the cord of the twin you want to reduce near the abdominal end. So you're very sure that you're holding the cord of the fetus you want to reduce. And once you hold the cord, how would you know you're holding it? So when you hold it and close the bipolar forceps, then and move it, the cord will move with it. And because you're compressing the cord, if you put color, there will be no flow. So once you know that you have got the cord, you can pass current and then coagulate the cord. So here you can see there is no flow now. The cord has been coagulated. So again, which procedure, when to do? Usually these procedures are done after 16 weeks in monochorionic twins, 16 to 18 weeks, because if you do earlier, the risk of fetal loss is higher. And again, RFA is less invasive than bipolar. And bipolar you cannot do. There is oligohydramnios, short, thick cord, because you need to introduce a trocar into the amniotic cavity. And the bipolar will not be able to hold a cord if it is more than 15 mm thick. So RFA would be of advantage there. But the advantage of bipolar is that it coagulates both the umbilical artery and the vein at the same time. So decreases the risk of fetal shunting occurring in utero at the time that the twin you're reducing is dying. So the live birth rate for the normal twin is almost more than 80% with RFA and bipolar, although lower with laser coagulation. But with the bipolar, because it is a bigger instrument, the risk of preterm labor is higher. So we had also published a series of 44 cases, which we had done till few years back, and there were 70% of the babies went home, Although we had 77% live births, some babies succumb because of prematurity, because prematurity in PPROM are one of the important complications. So even though we are reducing one twin to avoid neurological damage or death in the other twin, still, even after doing the procedure, there is a risk of neurodevelopment impairment in the surviving twin to the tune of 6 to 8%, 6.8%, which should be counseled to the couple before the procedure. Other condition where people have done intervention to improve outcome is posterior urethral valves. Because of obstruction to the urine flow, it leads to distension of the bladder, back pressure changes, hydroretronephrosis, renal damage, oligohydramnios leading to pulmonary hypoplasia. So one of the options is to put in a psychoamniotic shunt in selected cases. If it is a male fetus, chromosomally normal, minimally decreased Leica, ultrasound shows that the kidneys may still be functional, they're not very echogenic, and there are no cortical cysts, and there is still some Leica. So we can, these cases we can put in a shunt. So this is like the shunt that we use. One end is introduced in the bladder and the other end is in the amniotic cavity, and it drains the bladder with the point that the kidneys get decompressed, and further damage because of back pressure changes is avoided. But the Pluto trial showed that it may improve the immediate neonatal outcome, but there was no good effect on the long-term renal function and overall morbidity and mortality. So the shunts have sort of gone out of, they've gone into disrepute, and there were again a list of complications, most important being 50% of the shunts get displaced in a couple of weeks. So people thought a more physiological way would be to drain the bladder. Rather than draining the bladder, look at the problem, that is to fulgurate the posterior urethral valves. So people have used endoscopy, so they get access into the fetal bladder through the maternal abdomen and the fetal abdomen, and fulgurate the posterior wall of the posterior valves, posterior urethral valves. And it has shown that the survival rates and renal functions are better in fetuses who undergo laser fulguration of the posterior urethral valve rather than shunts. Coming to thoracic lesions, you may have congenital pulmonary adenomatous malformations. And these, if large, can cause mediastinal shifts and non-immune hydrops. Like Dr. Vanna said, most of them would increase in size till 28 weeks and regress themselves, do not require any intervention. But if the pleural effusion is very large, causing hydrops, you may have to do surgical intervention sometime. And usually the cystic ones don't reduce in size. So this was a patient we had with a large CPAM with a large cyst. So it's around 30 weeks we had put in a shunt, and so the shunt had drained the fluid, but 4 weeks later the shunt gets dislodged and she again developed pleural effusion. So around 35 weeks we had delivered her. Another condition is bronchopulmonary sequestration. So again, if you have an extralobar variety or a very large one, it can cause hydrops and pleural effusion. And again, here the option may be to put in a shunt, but then again, it is not taking care of the pathology. But if you can ablate the feeding vessel, it may lead to decrease in size. So we had a patient, a doctor couple, who came to us at around 29 weeks with a large extrapulmonary sequestration with huge pleural effusion. And this was the feeding vessel from the descending aorta. And they were very keen that we do some intervention for them so that the baby has a good outcome. So we had done a radiofrequency ablation for this patient successfully, which is the second case successfully reported in world literature. So we had ablated the feeding vessel with RFA, and on follow-up, we found that the lesion had decreased and the fusion has also decreased, and the baby did not require surgery after birth and is doing well, almost 1.5 years on follow-up. Another condition where people have gained success in doing in utero intervention is congenital diaphragmatic hernia, because we know it can lead to pulmonary hyperplasia and pulmonary hypertension. And the severity of these determine the survival at birth. So cases which we have severe CDH were observed to expected lung head ratio is less than 25% are candidates for improved outcome after doing the procedure. So here, what is done is, like, through an endoscope, you enter into the, with an endoscope, you enter into the maternal, the amniotic cavity, and then go into the fetus, enter the fetus's oral cavity, go into the trachea, and put a balloon in the trachea. So this prevents the fluid from the lung coming out and helps in lung growth. But you have to remove it again by 34 weeks, because if left in, then it interferes with the surfactant production. So it requires two procedures. But the randomized control trial showed that in fetuses with severe left diaphragmatic hernia, this procedure improves survival by 50% at 6 months of age. Although the results were not significant, improved, but not significantly better in those with moderate diaphragmatic hernia. Again, a word about cardiac intervention. People have intervened in aortic stenosis, especially where it was leading to like evolving left hypoplastic left heart syndrome. So we can enter with a needle through the maternal abdomen into the fetal heart and pass the needle through the stenotic valve, inflate the balloon and dilate the heart. So we had one case, which our pediatric cardiologist and we did together. And this patient had a successful outcome, delivered a term, but the baby did require a re-intervention after birth. As far as open fetal surgery is concerned, after the MOMS trial, which was in utero repair of meningomyocele, showed that in utero repair of meningomyocele reduced the need for shunting and improved more outcomes at 30 months of follow-up. And but was associated with maternal and fetal risk. Maternal risk are basically a risk of hysterotomy, preterm labor, a repeat cesarean section for delivery. But people are doing in utero repair in selected cases, and people are doing open with hysterotomy and also laparoscopic repair with good success. But again, you have to have a very stringent criteria for choosing your cases. So the other condition where we do intervention is ex utero intrapartum therapy. So it is not only a cesarean section, it is a way of facilitating neonatal resuscitation while the newborn comes out still on the placental circulation. And the anesthetist uses inhalational agents and tocolytics to allow uterine relaxation with partial delivery of the fetuses in cases of airway obstruction, like patients with chaos or neck masses or huge CPAMs. These modalities are used to access the airway while the fetus is still on maternal circulation. So it it converts the emergency situation into a more controlled situation. So we had this patient was referred to us at 22 weeks with a fetus with a very big neck mass, almost like initially like 5 to 6 centimeters. By the time she reached term, it was almost 18 to 10 centimeters in size. They wanted to continue the pregnancy. So we did exit at 37 weeks. It was a teamwork with anesthetists, neonatologists, the pediatric surgeon, the ENT surgeons, with many rounds of preparation in the OT as to how to proceed, how to approach with a successful outcome. I'll just show the video later because somehow it's not working in the attached file. So to conclude, fetal therapy is still evolving. Few centers have the expertise, and it is definitely a multidisciplinary approach. But then we have to be very careful about selecting our cases which are amenable to in utero treatment without compromising the outcome. And also counseling and informed consent is very important before proceeding with these cases. So I'll just quickly show the video. I'll just share that. Can you see the video? Can you see the video?
Not yet, ma'am. Not yet.
Not yet. Is it visible now?
Mm.
I think it's just, is it visible? I have to share it.
No, ma'am. No, ma'am.
I have to stop.
No, we can't see, ma'am.
Okay, I'll have to share it again. I think after stopping the slides, 1 minute. Okay, it's not running. 1 minute. Let's see.
You can take your time, Doctor. We want to see.
Okay, because somehow it was inserted in the slide, but it stopped working. me see if I can share it now.
Ma'am, while you do that, is it okay if I take a question?
Yeah, please carry on.
Somebody on the group is asking if there is any role for laser in CPAM.
CPAM, like I said, most of the time they would resolve. So you have to wait and see, or you can give steroids as a first go. Laser people have used, but I don't know. We have had two cases. In one, we landed with fetal death, and the other, it resolved. So it may be used, but I mean, it's not that there's not too much experience with its use to say that it is definitely a good choice. But if it is, I mean, it's like not like a standard way of managing like you have for intrauterine transfusion and the twins. So is it visible now?
Clearly.
Yes, ma'am.
So this patient we planned, so this was the first exit we did, and it was, I think, almost 10 years back. And so with the help of the anesthetist, we had sort of started. And so luckily it was a cephalic presentation. So we delivered the head, and then the neonatologist tried to intubate. They could not intubate the baby. Then they tried with a rigid bronchoscope. They could not. And despite multiple attempts, then we delivered the baby, handed over the baby while still connected to the cord and the placental circulation there. And then they did a tracheostomy. So this baby was on like sort of in uterus, like on the placental circulation for almost 40 minutes before the airway could be secured because the trachea was quite deviated because of the mass. So finally the airway could be secured and the baby taken for surgery and was successfully operated. So that was a huge teratoma. It's almost like 10 centimeters here. So I think that's it. I'll just stop sharing.
Absolutely amazing cases, ma'am. Interesting and difficult cases managed so beautifully because of your expertise. And thank you so much for enlightening us on this. Yeah,
thank you.
It's very helpful.
Over to you, Chinna ma'am and Sita ma'am. Thank you.
It's just amazing how we enjoyed all the cases by Dr. Vatsala as well as Dr. Vandana. And I think thank you, Sneha ma'am, for bringing us together and having this symposium on fetal medicine. And any words from Dr. Sita?
Yeah, pleasure was all to have all of you together. I'm sure everybody did and updated on this aspect. So, Sita, we would like to listen to you, and yes, your concluding remark.
Concluding remarks is that I think that we're very satisfied. It's been a very fruitful and informative session with all the stalwarts here. So thank you, Dr. Sneha, for this opportunity we all had here to listen to all these experts. Amazing cases and discussions. So thank you all the faculty for having joined in. Truly very informative. Thank you.
Thank you very much, Sneha ma'am, and we hope you keep spreading your positivity like this.
Thank you, ma'am.
All the best.
Thank you, Dr. Sneha. Thank you, Dr. Sita.
Thank you,
May I
Dr.
invite
Vatsala.
Dr. Sneha, madam, to please officially propose the vote of thanks?
Yeah, so I would like to thank the dignitaries who have joined, especially Dr. Jaideep Chang, the president of FOXI, and of course, Madam Deepika Dekar, whom we missed today, but she promised us to join soon, and Dr. Bhaskar Pal, of course, guest of honor, wonderful person, and of course, a great academician. Thank you so much for joining in spite of his busy schedule. At Bhubaneswar, he's busy in a physical CME. Still, he joined and graced the occasion. So special thanks to Dr. Bhaskar. Of course, all my faculties, right from Dr. Chinmay, Dr. Vatsala, Dr. Vandana, and Dr. Mandakini Pradhan, who was a chairperson along with me. And I have taken her to the entire Maharashtra, almost 5-6 societies we have covered, to know what exactly genetics is. And I'm very happy because I love to spread knowledge. And if I can be of any help to anybody, that is what the intention was. So I have actually taken her physically to 3-4 of my important cities of Maharashtra. I'm happy for having Mandakini Madam here, and of course all my chairpersons who have joined all the way from all over India. I have named them already personally, welcome them, and I thank all of them here. I thank my very important conveners, my very good friends, Dr. Chinmay Radha and Dr. Sita Ramamurthy Pal, for designing this program, not only planning but also execution of this program. Thank you so much, both of you, dear, from the bottom of my heart. And thank you. Thank you so much, Dr. Monica, who is such a hardworking, genuine girl,
I think
always
Dr.
very,
Monica
very.
needs a big round of applause. It was really, really
Thank you
smooth
so
the
much,
way.
ma'am.
Congratulations, Dr. Monica. Sorry.
Thank you, ma'am.
Yeah. And I appreciate Dr. Vidya Thobi and Dr. Rajeshri Paladi, who is the immediate past president and secretary of KASOGA, Karnataka State Organization.
Thank you, Sneha. Wonderful webinar and wonderful speakers.
Hello,
Thank
Vidya
you very
ma'am.
much. Hello. Hello. Yes.
Thank you.
I thank you all of you for being here, and of course, Sahiti for conducting this flawless session without any technical glitch. Thank you so much, everybody, and